Welcome and thank you for attending the 2020 National Hospital Alliance Virtual Conference. Our conference is entitled Quality Care and Support for Women Heart Patients. This year, during the COVID-19 crisis, Women Heart is hosting its annual conference for our hospital partners, board members, scientific advisory council members, corporate advisory council members, Women Heart champions, partners, and friends. We are doing this for everybody online to continue our engagement and continue advancing our efforts in women's heart health. Over the next 2 days, you will hear from our NHA members, partners, and Women Heart champions on supporting, educating, and advocating on behalf of women living with or at risk of heart disease. We'd like to take this moment to thank our sponsors for their generosity in supporting the NHA conference. The agenda that you see before you will contain a lot of very exciting and informative information. You're going to hear from 7 great speakers today, and we're going to cover a range of really critical topics that will move forward the work of Women Heart and all of our partners in addressing the issues and critical the critical issues for women with heart disease during the context of this pandemic. In particular, I wanted to highlight a few special things. We will obviously be talking about gaps in cardiovascular disease disparities among the most vulnerable in the country. But as well, we'll be looking at the challenges and opportunities for women heart patients in the context of their healthcare. And we want to make a special mention, and I'll have a special session today on the confluence of heart disease and mental health as a challenge that has been particularly acute during this pandemic. And then we also want to make sure that we address cardiac rehab, yet another service, another part of healthcare that has suffered dramatically during this time. Tomorrow's agenda will transition us a little bit to focus more on key policy issues facing women with heart disease. We will look at trends and medical innovations, as well as considering heart disease over a lifespan. And then finally, we'll finish up with looking at how Women Heart has been supporting women with heart disease through this time, and in particular through our Champions Program and volunteer engagement and support, as well as looking at the uptake of virtual patient engagement, again, during this time that we have really ramped up. Just to sort of set the stage for the next 2 days, we've just got a few minor housekeeping issues. One is that this conference is being recorded and will be shared along with the presentations immediately after the conference. If you have questions, please make use of the Q&A button that is at the bottom of your screen to submit any questions for the presenters throughout the course of the conference. If you want to participate in the discussion during the course of the open discussion sessions, please feel free to use the raise hand button. And we are very eager to hear from you, so please use those as much as you like. And also, please add your name and affiliation to the conference chat. Again, we want to make this as interactive as possible in this virtual space. Participants can attend the entire conference or can attend portions of it. It's the same link that you have in your emails. Video and audio will also be disabled for conference participants unless otherwise noted or highlighted. And finally, we would really encourage you to help us to improve as we go along from year on year by taking the evaluation as you log out each day. So just a quick snapshot of Women Heart. Women Heart has for over 20 years continued to be the only patient-centered organization solely dedicated to serving the millions of American women living with or at risk of heart disease. And we do this through patient support and education, advocacy, and national and local partnerships. Women Heart was founded when 3 women had heart attacks, and they survived and recognized that they had the same experience with their heart disease journey. And they wanted to provide support and advocate for women living with heart disease. There are 4 common themes that these women wanted to address. Number 1, misdiagnosis. And we're going to hear a lot about misdiagnosis over the course of the next few days. Number 2, delays and disparities in healthcare. All of us know that any delay has really significant negative consequences on outcomes. And so that's a really important aspect of care that we need to be addressing. Number 3, fear, the feelings of fear and isolation, and the feeling of feeling alone. And then the last is little or no support, very little information for women on heart disease. There are a number of gender-specific challenges for women, and they impact the care and treatment of women with heart disease, but also they impact overall heart disease outcomes. And here on the slide are just a few. We've got general risks for being a woman, including hormones and pregnancy, as well as peripartum vascular remodeling. We also have symptoms that not are necessarily specific to women, but maybe show up in women more often, including fatigue, nausea, and jaw pressure or pain. 90% of patients who experience broken heart syndrome are women. And yet we see the active participation of women in CVD research to be really low. Only 30% of participants, subjects in CVD research is made up of women. And the number is even lower when we talk about heart failure research. There is a, the figure is 60% of heart valve replacements are done in women, as well as having a much higher prevalence of SCAD. And finally, women have a 3 times higher rate of mitral valve stenosis, and as well double the rate of depression leading to sudden cardiac death. So why is Women Heart here? And it really is to address many of the things that you saw on the former slide. For the last 20 years, Women Heart has also continued to bring awareness to heart disease in women, because heart disease continues to impact millions of American women and is the #1 cause of death among women, #1 cause of death among women, killing more women than all cancers combined. Heart disease is increasing in women aged 35 to 54, a much younger age range than we would typically consider in terms of the age when women experience heart disease. The overall awareness of heart disease risk remains really low among women at 56%. And women of color are disproportionately higher impact and at higher risk for heart disease and death. And women continue to be less likely to have non-invasive diagnostic testing at the initial point of care. The treatment that is recommended to them is often more aggressive than necessary. And the referral to cardiac rehab, where it might be indicated, is not as high after a heart event. Women are also underrepresented, as we talked about in the previous slide, in clinical trials, which can impact care and treatment for women. So how does Women Heart then organize the support that we provide? Women Heart relies on the support of our board of directors, cardiologists and researchers who make up the Scientific Advisory Council, volunteers, which in Women Heart we proudly call Women Heart Champions, industry partners that make up the membership of our Corporate Advisory Council, and hospitals within the context of our National Hospital Alliance to reach women with known disease and those who are unaware of their heart risks. In addition, we rely on strong collaborative relationships with national partners and generous donations from our supporters across the nation. Our volunteers, our Women Heart Champions, are at the heart, literally at the heart of the work of Women Heart. And this is the reason we are able to accomplish so much. Women Heart has trained over 950 women heart patients at our annual Science and Leadership Symposium at the Mayo Clinic. This created an army of women heart patients around the country that share their stories, educate women about heart disease, and provide critical support for women living with heart disease. Our Women Heart Champions are fearless in partnering with hospitals, local companies, places of worship, and other venues to ensure women know their risk and get the support they need on their heart disease journey. This slide just shows you some of the important aspects of programming across Women Heart. In the first column under patient and community education, as you see at the very top of that is Science and Leadership Symposium at the Mayo Clinic, which is really the beginning of the journey and our collaboration with each Women Heart Champion. Once they graduate, then they become part of the network and really part of the sisterhood that is the Women Heart Champion Network. There is also a very important tool for communication and education called the Red Bag of Courage that is often handed out to patients who are maybe have just gotten a diagnosis or have gone through a procedure in hospital. And then we have a monthly newsletter called Heart to Heart, where we try to share the latest information about women and heart disease. And then there is also a really important program called Women Heart at Work, where companies can request a Women Heart Champion to provide education on women and heart disease in the context of their workplace. Let's move on to patient support, and really the heart of that pillar is support networks, or virtual, at the moment, virtual support networks, where our champions have become true experts in running Zoom meetings where they are providing virtual support groups for women living with heart disease. We have also continued the program of Sister Match, which takes champions who have volunteered to answer any questions that newly diagnosed women might have. And that program, we have seen continued success with that program throughout the pandemic. We've also had incredible success with our Heart Scarves program, where champions and others knit scarves to be able to distribute them to newly diagnosed women heart patients. And we've had an overwhelming response, I think, as an activity during this time of COVID. And then we have a broad online support community that has been extremely active, again, during this time. And then the last pillar I'll quickly run through is our advocacy pillar, where we train champions on how to be strategic and action-oriented in their advocacy efforts. We have held and hosted congressional briefings on various topics from PAD to heart disease and pregnancy. We also put out from time to time public policy call to action, where we gather and encourage support from our Women Heart community. And then we also hold an annual dinner called the Wanger Awards, where we take a moment to recognize the brilliant efforts of our partners and legislators and cardiologists and the overall community of folks dedicated to addressing women with heart disease. So just a quick moment to talk a little bit about the Women Heart National Hospital Alliance that many of you are members to. The NHA is comprised of hospitals nationwide committed to providing the full spectrum of women's heart care. This alliance highlights hospitals with gender-sensitive cardiovascular care unit and provides hospitals with access to women heart educational materials developed by the nation's medical leaders in women's heart health, and patient support provided by Women Heart champions. Our partner hospitals have a strong commitment to advancing women's heart health and are oftentimes the leaders in women's heart health in the country. They support women with heart disease. They want to work with us in raising awareness among clinicians and staff and employees. They want to have their hospital be branded for gender-sensitive cardiovascular care. And they also want to work with us in raising the visibility of women's cardiovascular services. And finally, along with us, they want to improve patient activation, health outcomes, and overall satisfaction. In a study of support networks provided at the NHA hospitals, it was identified that women heart patients had higher completion rates of cardiac rehab, which we know is critical to positive outcomes, increased medication adherence, reported lower levels of stress, reported higher levels of social support, and they are more likely to be an active participant in their own heart health care. This study recognized the important role of healthcare and patient support through peer-led support groups. Supporting women heart patients and the millions of women at risk of heart disease continues to be needed even to this day. Patient support continues to be critical beyond the hospital bed, and it goes far beyond. And together, we can all continue to save lives. I will hand it now over.
Thank you, Selena. Next, I would like to take this moment to introduce our first presenters at this year's conference. We have Ryan Gooch. Ryan Gooch is the Executive Director of the Partnership to Advance Cardiovascular Health, a stakeholder advocacy coalition where he works to advance public policies and practices that result in accelerated innovation and improved cardiovascular health for heart patients. Second, we will hear from Dr. Estelle Jean, who's a board-certified non-invasive cardiologist with MedStar Cardiology Associates at the MedStar Heart, at the MedStar Heart and Vascular Institute. I would like to welcome Ryan to the conversation today.
Thank you. Thanks, Calandra. And thank you to Women Heart for having me today. Really appreciate it. I want to also thank Amy Friedrich-Karnick, who is the VP of Advocacy at Women Heart. And I work closely with Amy and always appreciate her partnership and help. And just want to say that Women Heart has a true champion in Amy and a very steadfast advocate. So thanks for Amy's work with Women Heart. So I want to, first of all, I can advance the slide. So today I'm going to talk a little bit about what COVID-19 has revealed about America's healthcare system. And my talk is really kind of broken into two parts. One, I want to just cover the policy response that we've seen since February, March of the pandemic. And then I want to talk about some of the patient and provider takeaways that my organization has gathered through some calls that we have held right at the peak of the initial emergency period of the pandemic. As Calandra mentioned, the Partnership to Advance Cardiovascular Health, you'll hear me call it PATCH for short, seeks to advance public policies and practices that result in accelerated innovation and improved cardiovascular health for heart patients. Generally speaking, we are a public policy nonprofit. And so what we work to do as a coalition of different groups is come together and work on issues that affect appropriate access to patient therapy. Women Heart is a member, and we appreciate their partnership. And we can be working on things like at the state and local level, health plan level, like prior authorization, non-medical switching, copay accumulator programs, all the way up to federal legislation. So a lot's happened in the last 7 months, a lot of disorientation. So I want to just go down to brass tacks of what's really kind of happened on a fundamental level over the last first half of this year. So on January 31st, Health and Human Services declared a public health emergency from COVID-19. On March 13th, the president then declared a national emergency. When that happens, that gives the Center for Medicare and Medicaid Services the ability to issue and grant waivers for individual states and for health plans that they manage, Medicaid, CHIP, others, to create some flexibility in the system. And so we saw that initially. Then on March the 27th, the Coronavirus Aid, Relief, and Economic Security Act was signed into law, CARES 1. You've heard this week that Congress is now discussing CARES 2, but we won't get into that today. So what did these waivers and the CARES Act do? So generally speaking, I think CMS Director Seema Verma put it really well. And this, essentially what they were trying to do is create a lot of flexibility in the healthcare system and create some innovation or allow innovation so that clinicians could reach their patients in a safe way. But specifically what happened? A lot of things, and you're aware of a lot of those things when it comes to checks cut to citizens, support for hospitals, personal protective equipment, all these kind of things. But I want to talk about patient care. So there are a lot of different things that happen on the public side that we could talk about. But here are a few listed that kind of illuminate some of the major changes that happen throughout the healthcare system. Extensions were granted for prior authorizations. Some prior authorizations were waived. Licensed clinicians were allowed to practice out of state to ease clinician burden in states that were highly impacted by COVID. One I think most people are familiar with is that telemedicine utilization was loosened. So people were able to use telemedicine including audio telemedicine. So not just audio-visual like a Zoom call, but an audio call was allowed for the first time. Extensions for prescription refills were granted, and a lot of paperwork was cleared away so that clinicians could focus on patient care. So on the private payer side, that was the public payer side. On the private payer side, what happened? It's more of a complicated question, frankly, because it depends on the state, it depends on the health plan, depends on what level of health plan you might have. But generally speaking, I think that you can put it into 3 or 4 buckets. What most large health plans did in terms of loosening up policy during the emergency response period. One was they waived copays and cost sharing for COVID diagnostic testing. Prior authorizations were waived for COVID testing. Some plans waived prescription refill limits and for maintenance medications. And most plans expanded access to telehealth or created nurse and provider hotlines for patients. So that's kind of the really 30,000-foot level, what happened in terms of policy. So a lot of flexibility put into the system. Now I want to talk about patient-provider takeaways, which will hopefully foster some discussion at the end of the talks. Patch, at the beginning of the pandemic, started holding calls with our member partners. And eventually those calls, in a good way, snowballed into all of these organizations that you see on the screen, joining every other week to talk about central issues that were happening in the healthcare system for chronic disease patients. What's interesting, you'll see a lot of likely characters on this screen. Women Hearts up here, PCNA, number of different heart groups that diabetes groups as well. But what's interesting is that we also were able to pull in the National Governors Association, the National Association of City and County Health Officials, the National Conference of State Legislatures. And the reason that was significant was that we were able to kind of pull together the policymaker and policymaker support community and the people that were being affected at the clinic level, the patients and the providers. And as these massive changes were kind of being pushed through the system and watched by the National Governors Association and others, we were getting real-time feedback from patients and clinicians about how this was actually being pushed through at the clinic level. And so it fostered this really interesting dialogue about what was going on in the system. So what were we hoping to accomplish with these calls? Well, frankly, this was almost a mistake, frankly. I mean, initially we held these calls to just share resources. As everyone here knows, when the pandemic happened, every organization was canceling conferences, moving to Zoom, trying to figure out how we were going to function at home with kids and everything else. So what we tried to do is just bring everybody together to share resources. We figured there would be a lot of questions about COVID and heart disease specifically. But eventually that turned into discussions between these patient provider groups and government support organizations about these massive policy shifts that were being pushed through the system. And we were answering questions about this fast moving policy environment. But what we realized by the end of the call series is that what we were really doing is drawing really broad lessons in an extraordinary time about chronic disease care in the United States. And we figured that, even though we were in kind of an extraordinary, unprecedented situation, there were some things that we could learn about chronic disease care in America, in an emergency situation, but also in normal times, whatever those might be at this point. So I'm going to walk through 4 kind of narratives, lessons, discussions that I think are motivating the policy and advocacy community now. And I'd be open to thoughts and critiques on these things as well. But the first one's easy, frankly, and that is around telemedicine. So on the screen, you see Dr. David Charles. Dr. Charles is a neurologist actually at Vanderbilt University and also an expert clinician when it comes to telemedicine. He's been following the telemedicine policy debates for years. And I think it's important to note that telemedicine is not new. Adoption of telemedicine is new. And when the regulations were loosened on telemedicine in April, March of this year, as you all know, there was a huge influx of telemedicine visits that happened throughout the healthcare system. Dr. Charles recounts in this quote, you can see that in 1 week, they saw more telemedicine visits than they had done in the entire year. This is at Vanderbilt University in Nashville, Tennessee. Some key points here, I think, is that audio visits as well as visual visits were reimbursed, and that's important. That also allowed for this kind of swift adoption. And we found, I think patients and providers found that telemedicine works. It worked, and it worked particularly for helping patients that need chronic disease management, that need more frequent touches with their specialists or their clinicians. You know, we do need to ask ourselves, you know, why has there not been this kind of swift uptake of telemedicine at this point? And I think it's a pretty simple answer. I was actually on a Zoom with the Senate Help Committee, a staffer there who said, we love telemedicine, but we don't want to pay for it. And that's why we haven't had such swift adoption of it, but that's changed. And importantly, in the last few days, CMS has actually extended the telemedicine regulations for 60 more days. So we're going to see, I think we're going to see some serious changes in the telemedicine landscape. So before I get to lesson 2, I wanted to bring up this article from the New York Times. And this is something that clinicians can speak to, you know, unfortunately a lot right now. And that is, you know, during the middle of the first kind of emergency period around COVID, there was this situation where, you know, the COVID wards were full, but the stroke and heart attack wards were empty. And docs were asking themselves, where have all of these patients? I mean, we know people are still having heart attacks and strokes. Where are these people? And that gets to lesson kind of 2 that we discussed, and that's around continuity of care. You could take a second to read Dr. Anderson. Dr. Anderson, just serendipitously, is from Nashville as well, Tennessee, like Dr. Charles, but he has a tragic example where a patient was more fearful to go to the hospital to treat his AFib instead of than stay at home, and over the weekend, unfortunately, passed away. And we're hearing too many of these stories. But the lesson really gets back to continuity of care. And I think that the discussion is kind of falling into 2 buckets on this. One is you need to seek care if your cardiovascular disease, your diabetes, your kidney disease is out of control. And I think that a lot of advocacy and patient groups have tried to put that call out there as these, you know, wards have really emptied in the last few months. The second kind of bucket I think that this conversation is happening in is around delayed care. We know there's going to be this delayed care wave. It's happening to a certain extent now, and I have a stat here to share with you to kind of illustrate this. In March, we're seeing some data now that death rates for heart patients spiked 27%, while emergency room visits plummeted 23%. And then the 5 states hit hardest by COVID, so those would be Illinois, Massachusetts, Michigan, New Jersey, New York. They saw 8,300 more deaths from cardiovascular disease March to May than they saw last year. So there's some serious implications for a continuity of care here in the emergency period, but also out of the emergency period. The third one, racial disparities. And honestly, we could have a whole 2-day conference just on this. You know, there was a vigorous discussion about racial disparities, and obviously this is occurring outside of just the healthcare arena right now across the country. But it's pretty simple. I just read an article on this just a few minutes ago, and this stat unfortunately illustrates what's going on across the country. In New Orleans, as of June 5th, 492 people died from cardiovascular disease. 77% of those were Black. We see this in states across the country and cities across the country. This is the case in St. Louis, Michigan, Milwaukee. In Michigan, for instance, Blacks make up 14% of the population, but 40% of COVID deaths. We know that people of color suffer from cardiovascular disease and diabetes at higher rates than whites. And we know that those diseases contribute to complications with COVID. And so I can't put it any better than Dr. Ferdinand does here. And that's the tragic higher COVID-19 mortality among Black Americans confirms inadequate efforts on the part of society to eliminate disparities in cardiovascular disease. And finally, the last lesson or discussion I think has been had in the policy community is that utilization management can impede appropriate patient care. That's pretty, I think in a way, it's been tacitly admitted by a number of policymakers and payers, frankly. And it's been admitted by the fact that one of the first things that happened when the pandemic struck was that utilization management tools were suspended. Prior authorizations were suspended. 90-day refills were suspended. And so we see this kind of tacit acknowledgement that utilization management can impede appropriate patient care. This is unfortunately not new to the cardiovascular community. As we have understood cardiovascular disease better, we've seen more utilization management controls on medications. And this is alarming because when you look at the large trends, from 1950 to about 2010, every year we saw a decrease in death from cardiovascular disease. There was even discussion around the turn of the century that CVD was going to actually be below cancer for cause of death in America. But in 2011, we've seen an uptick for the first time. So we are actually seeing the progress we made over the last half century reverse. And so we need to ask ourselves where comes in to that question. And if we're actually impeding appropriate patient care from some of the utilization management policies that we've put in place. So that is it for me. I just want to say thank you again to Women at Heart for having me on. If you would like to hear smarter people talk about this a little more in depth, shameless plug, we will be having a webinar on August the 13th at 1 p.m. about these issues. All the clinicians you see on the right will be answering questions and diving deeper into these kind of narratives or policy changes. And so we would love to see you all there. You can email me here, or also Amy Friedrich Karnick can get you in touch with me as well. And thank you so much. Thanks, Calandra.
All right. Hi, thank you very much to Women Heart for allowing me to participate in this webinar today. And just going to pick up in terms of what was previously mentioned, but specifically talk about managing heart patients during the COVID-19, including virtual patient care and considerations. And the main topics that I do want to cover is what have we learned about COVID-19 effects on patients with heart disease and cardiovascular risk factors, and how we're doing and from what we've learned about managing heart patients who develop COVID-19, as well as how we're using telehealth and managing non-COVID patients with their heart disease and risk factors remotely, as well as some of the unique challenges that we are seeing with minority population. So just a brief overview. Patients infected with the severe acute respiratory syndrome, coronavirus 2, and its clinical disease, COVID-19, are often minimally symptomatic or asymptomatic. But there are a smaller subset of patients with cardiovascular disease risk factors and with established cardiovascular disease that represent a very vulnerable population when suffering from COVID-19. And patients with cardiac injury in the context of COVID-19 do have an increased risk of morbidity and mortality. And this is one of a summary from the initial published data out of Wuhan, China. And in their particular case series, the fatality rate for COVID-19 was only 1.4 to 2.3%. But as we've seen in other regions in patients with cardiovascular disease or with risk factors, the numbers are actually higher. But from that cohort, the cardiovascular patients with cardiovascular disease had a 10.5% mortality rate. Those with hypertension had 7.3% mortality rate, and those with diabetes had a 6% mortality rate. And this is the most recent published data from the CDC with preliminary data up to July 11. And by far, patients had hypertension as the most frequent underlying medical condition, followed by obesity, as well as metabolic disease, and then followed by cardiovascular disease. And this is similar to what we've experienced in our hospital, for which hypertension, obesity, diabetes, and cardiovascular disease has been one of the main, several of the underlying conditions that leads patients into our intensive care unit with more critical disease. And why does this occur? How is COVID able to cause such severe illness? Well, it's currently thought that the renin-angiotensin system plays a central role in the pathogenesis of COVID-19. And in this view here, the SARS coronavirus 2 is able to enter the cells within the lung lining and other cells in the body through this ACE2 receptor. And through various mechanisms, after it binds, it leads to an accumulation of angiotensin 2, and through the effect of angiotensin 2, you have a release of your sympathetic system, as well as vasoconstriction and sodium retention and fluid retention through the mechanism of aldosterone, as well as fibrosis that leads to many of the deleterious cardiovascular effects from coronavirus 2. And this is another summary showing the impact. So after it has entered the cells, there are many processes that occur that leads to increased inflammation, which leads to damage to the myocardium. So you develop fulminant. Some patients can develop myocarditis, as well as congestive heart failure, arrhythmias. And in particular, you can have plaque instability and rupture that leads to acute coronary syndrome. And part of the cascade that leads to severe manifestation of COVID-19 is the cytokine storm that can occur, for which currently we do have various treatment modality that tries to interfere with interleukin-6, for example, to try to decrease the inflammation in a cytokine storm. And so one of the original concerns related to heart patients was, is it safe to continue taking ACE inhibitors or their angiotensin receptor blocker medications? And based on the other chart that was shown, one of the main concerns with the ACE inhibitors is that it can lead to an upregulation of the ACE2 receptors. But thankfully, the more recent studies that have been published have not shown an excess mortality in patients taking their ACE inhibitors. And many of the societies have published recommendations and guidelines to not discontinue ACE inhibitors because there isn't any data to support that there is a worse outcome. And the concern, of course, is if you stop a patient's ACE inhibitor and they have congestive heart failure, that they can decompensate, or their blood pressure may become uncontrolled, which then can lead to ongoing risk factors for a severe COVID-19 infection. And this is a recent study published for which they analyzed patients in their cohort who were already on Ramipril group, and they did not find a decrease in the death rate for the ones who were taking Ramipril. And another important component of the severe infection is elevated troponin. So many patients, when they will come into our emergency room, will have their troponin assays assessed. And what we have learned from various studies published is that when it is elevated, it does lead to a worse prognosis. And in one particular series, an elevation in troponin had resulted in a 60% mortality rate. And there's various reasons why the troponin can be elevated, but majority of patients, we think of it more as a demand ischemia, where there's just a mismatch with the demand of the severe infection. But of course, you can have acute coronary syndrome, which is thought to be due to either acute plaque rupture or a hypercoagulable state from the infection. And some patients, in particular, we know women have a higher incidence of spontaneous coronary artery dissection. That can be an important consideration for patients presenting with an abnormal EKG with ST elevation MI. And this also can be due to arrhythmia. So when patients developed atrial fibrillation or atrial flutter, then that can result in an elevated troponin. But the key is to remember, for the subset of patients who do have an elevated troponin, that it does have a worse prognosis. And as Ryan previously mentioned, one of the earlier efforts was stay at home, but unfortunately that did translate to many patients and some recommendations from providers as well to avoid the emergency room due to concern for contracting the coronavirus. And as illustrated here in a recent published study, there was a significant reduction in STEMI cath lab activation in the United States. And in particular, they looked back to 2019 for the usual standard of care. And within the first 3 months, in particular in March, there was a drastic decrease. And from both US studies as well as international studies, the decrease has been as much as 40 to 50%. And this was a recent published study out of Massachusetts, where they looked within the Partners Health System in their tertiary center, and they found not only a reduction for ST elevation MI, but they also saw reduction for chest pain, heart failure, stroke, and other cardiovascular condition. And the decrease drastically became more pronounced as the number of COVID-19 infections became more noticeable in Massachusetts. And what they also found was that there was a statistically significant decrease in the hospital stays. So on average, during this time period in March, patients were averaging 4.8 length of days within the hospital versus the usual standard was 6 days. So there also was a push to get patients out of the hospital sooner. There was a trend towards higher mortality in this particular series out of Massachusetts, but it was not statistically significant. And so how do we manage these patients when they come in with an ST elevation MI? This is based from the recommendation from the European Society of Cardiology, and it is still standard of care. If someone comes in with a network with ST elevation MI, the standard of care is to proceed with primary PCI with a door to balloon time goal of less than 90 minutes. Now, if you are not within network or there would be a substantial delay, then you can consider doing lytic therapy as an alternative treatment, but the goal should still be to maintain standard of care with appropriate usage of PPE to decrease transmission within the team within the cath lab. And so for patients, though, who are presenting with non-ST elevation MI, if they are low risk, then you should go test them for COVID-19 and consider non-invasive testing, as typically we would do as standard of care. But as the severity increases, you do want to proceed with early revascularization and standard of care with PCI. And so as we're transitioning now into the outpatient setting, it is really important to continue to access our patients with usage of virtual care. I know early on in my panel, patients were really not wanting to use the services of virtual care because they were waiting until the virus went away so they can have their usual office visits. But as we're learning, that's still here. COVID's not going anywhere anytime soon. So we want to continue to engage our patients to prevent any gaps of care. And through telemedicine, we're able to increase our outreach to patients and expand the home monitoring capabilities. And of course, as the various policies are being done from a governmental level to ensure appropriate reimbursement. And throughout this process, there has been deregulation, but of course, remembering that we do have to have judicious uses of resources as we also want to minimize the transmission of COVID-19 to our office staff and other members of the team, and to not do necessarily routine testing, but to continue to shift any outpatient testing to what's urgent and would change management and the patient care and outcome. And so various tools can be used to effectively manage someone within telemedicine. Many of my patients still question using it as a primary modality because they're so used to having a stethoscope for us to listen to their heart, to examine their lungs, but there is still a lot of treatment management and change in clinical outcomes that can occur with usage of telemedicine. And you can still gather a lot of data through usage of various technologies. So ideally, the patient should have their own blood pressure machine, as well as a pulse oximeter that can help with their oxygen assessment. And for patients with congestive heart failure, making sure that they do have access to their scale. So any adjustment to their diuretic regimen can still occur with the telemedicine visit. And there are capabilities using telemedicine stethoscope for us to be able to listen to various rhythms and alternative ECG monitoring methods. So you can do monitoring leads as well as smartphone enabled mobile devices and health devices. So it runs the full spectrum in terms of, iPhone, the Apple Watch versus Fitbit or KardioMobile. I've been really impressed by some of the technology and the quality of some of the ECG monitoring that has helped and aided with monitoring various arrhythmias. And we can send patients to various heart monitoring, such as a Zio patch, in order to do more prolonged monitoring up to 2 weeks of their arrhythmias. And lastly, I know we will be discussed at another session, but cardiac rehab is now transitioning to more of a virtual session. And so that's also an opportunity for us to continue to take care of our heart patients during this pandemic. And so briefly, uses of echocardiogram, based on the American Society of Echocardiogram, it is recommended that we follow appropriate use criteria. So if the echocardiogram will result in change in clinical treatment plan and diagnosis, then echocardiogram should be performed in a patient with COVID-19, but please try to limit the amount of exposure and focus the study to answer the question at hand. And it can, and of course, consider using droplet precautions or in PPE in the appropriate setting, in particular for TEE. Droplet precaution is recommended. And these testing can be done in the echo lab, in the cath lab, the EP lab, the ward, or the emergency room. And proceeding with stress testing, various societies do recommend, again, to use the testing if it's going to change management, and preferably using pharmacologic nuclear stress tests that has the least amount of potential transmission by doing the pharmacologic option versus the treadmill portion, where there can be more aerosolized component with and concern for transmission related to COVID-19. And of course, with the nuclear cardiac imaging, you want to use the protocol with the shortest scan time and the lowest staff exposure. And cardiac CT is not available at every hospital, but you can consider if you are in a tertiary center and the patient, for example, with atrial fibrillation, and you want to make sure that there isn't any evidence of thrombus in the left atrium. And so cardiac CT can be a fantastic modality to answering that question while minimizing the risk of doing a transesophageal echocardiogram before a planned cardioversion procedure. And cardiac MRI in the acute setting should really be used selectively. But actually, just today, I was reading an article published in JAMA looking at the long-term effects on the myocardium, and a randomly selected 100 patients who had recovered from COVID. And they actually did find within that cohort of patients that there was about a 70% evidence of involvement when they've used various cardiac MRI technology. And lastly, vascular screening, be it carotid duplex ultrasound or abdominal ultrasound. For the routine patient for screening, would recommend deferring until a later date. But of course, for more urgent indication, they should be used with appropriate precautions, as well as various other screening modalities that can be very helpful in our female patients, such as calcium score, which is very effective at looking for evidence of calcification or hardened plaque arteries. But again, in the presence of the need for screening, can consider and discuss the pros and cons with the patient of doing it at a later date. And lastly, various procedures, be it cardiac catheterizations or transcatheter interventions and cardiac surgery or EP procedures. It will need to be customized to the institution's policies and their procedures, but ideally the patients, you do want to know their COVID status in advance and to plan appropriately for all elective procedures. And this will be discussed at a later date, but as we're continuing to try to narrow the gap and taking care of our patients with heart disease, you want to make sure that you're also targeting patients who have been, as it's been discussed in the news, are higher risk for healthcare disparities. And as we know, Black and Hispanic patients are twice as likely as whites to die from COVID-19, and the hospitalization rates were 4.5 and 3.5 times higher than those of whites. And so some of the potential explanations, higher prevalence of risk factors, which was previously mentioned. Many live in densely populated areas, multi-generational households, rely on transportations, or being an essential worker where you're having work exposure. But to date, there doesn't appear to be any genetic predisposition that's been found, but there are hypotheses related to either overexpression of ACE2 receptors or cardiac sarcoid or sickle cell disease, and how it may be a potential explanation for the higher incidence within a Black population. And this is the most recent released data from the CDC, again, showing a much higher hospitalization rate in American Indians or Alaska Native, Blacks and Hispanics versus whites and non-Hispanic, Asian, or Pacific Islander patients. And as we will hear further, but we know that access to healthcare is only 20% of fixing and narrowing the gap. So we really do need to pay particular attention to how to get more of our patients engaged with heart disease during this process to make sure that they're optimized from a blood pressure standpoint, cholesterol, congestive heart failure, and helping them to also remember that their best care for acute heart attack is still within the hospital, and that includes stroke as well, and to be that partner with them to reassure them that it's safe to be in a hospital, and it's much better than if they decide to stay home. Okay, and so these are many of the components of the healthcare disparities that continues to result in this gap, but we have to think about their economic stability, their neighborhood and physical environment, their education and access to food and community and social context, as well as the healthcare system as we try to improve health outcomes in our most vulnerable populations.
Thank you so much, Dr. Jean. And I'd like to, we're a little bit over time. I apologize for that, but I do want to take a question if we have them. What we have, Ryan, if you want to come back on the line on camera and join us here. The first question I have, just a reminder, if you have questions for the presenters, please use your Q&A button at the bottom of your screen, or you can raise your hand. It may be at the bottom or at the top, depending on whether you're on an Apple product or you're on Android or PC type of platform. But the first question we have, I think, is for you, Dr. Jean. Many heart patients are on blood thinners, aspirin, beta blockers. Does that afford us any protection if we contract the virus?
Great question. So yes, I didn't talk about the blood thinning component, but as one of the things that was mentioned was the inflammation, the risk for blood clot formation. So that was one of the things that we learned early on as far as the higher incidence of stroke, which is due to the body's revving up its blood clotting component and causing strokes and can be an important cause of heart attack. And so part of the standard treatment in patients in the hospital is to be on blood thinning medication. And the higher the risk, the higher the markers of inflammation, part of the protocol in many hospitals is to put them on blood thinning medications. Now, as far as aspirin, some of the earlier concerns was about the safety of NSAIDs. Now, the FDA has stated that there is not any concern, but if a patient with COVID-19 does have a fever, we do recommend using Tylenol instead of the NSAIDs, but there isn't any adverse or higher risk of developing severe COVID-19 infection if you do take something like an aspirin or ibuprofen, naproxen medication. Beta blockers, if that's part of your standard treatment and medication, please continue it because it can be very crucial and important for patients with established, a heart disease in terms of prior heart attack or congestive heart failure, so those patients can continue it, but there's no particular data per se of it giving additional protection. Now, lastly, related to statin medication, there are some potential theories about it adding additional protection through cardioprotecting the heart and causing plaque stability, as well as what we've known statin has done in terms of reducing inflammation in patients, and that's why we prescribe it for protection of plaques and prevention of heart attacks and stroke in the future.
Thank you. We have another question about, do you have data on heart transplant patients and COVID?
Not any particular that I saw published, but patients with heart transplant should be closely treated by their heart team, and any adjustments to the immunosuppressing medications would be done by them as well. But if a patient is, for example, on the list to get a heart transplant, they're still recommending to proceed with it, but of course you do want to know their COVID-19 status beforehand so that the team can be prepared accordingly for them. But you do treat them along as you typically would for any severe infection where you may have to adjust their immunosuppressant medications, and of course have very close monitoring of their hemodynamics while you're managing for example, if they have congestive heart failure or any other conditions.
Thank you. This next question is for Ryan. Do you see telemedicine growing even after COVID? And what are some of the pitfalls we should think about from either a policy or medical perspective of this new technology?
So I think of every kind of innovation that's been adopted or pushed forward as a result of this public health emergency. For policymakers, I think telemedicine is the one that they're most willing to embrace for the long term. And you've seen Administrator Seema Verma make note of this. I think that honestly, it's one of these situations where the market is really going to determine this. I mean, there are so many people at this point have had my family, we've had one, at least one, since this crisis. And I think that most people think that it's a good thing and it's worked well. And I'd take Dr. Jean's thoughts on this too. I mean, from a policy perspective, some of the pitfalls, I mean, there's a discussion about broadband access, obviously for rural areas, but also urban areas, whether or not people can afford, good internet. Now, this also gets back to the question of, and this is why the audio versus audio visual policy question is important. Right now, you can use your cell phone to do a telemedicine visit. That might change, and that would obviously decrease access to telemedicine. So that's the one thing. The audio piece of this is the one probably thing that there may be some debate. I would imagine that could increase or decrease access. But Dr. Jean, I would take your thoughts on the medical perspective in particular.
Dr. Jean?
Yeah, I mean, the audio component, actually, that I just was having a conversation about that. I am concerned about the decreased reimbursement and what it can lead to already a vulnerable population who then will be forced to, for whatever reason, interface with the community. And if it's not safe, potentially be at higher risk. So, certain areas of the country, inner city or more rural, may not be able to do the technology. But from a medical perspective, from an office standpoint, if you're going to get reimbursed at a lower rate for that audio visit, then you're going to force these patients to come into the office. So one of two things may occur. Again, as I stated, higher potential risk of exposure for a routine visit that really can be effectively done via phone, or if the patient just won't interact at all. They just won't. They'll wait until COVID's, over, and that's not optimal. I mean, I've treated so many patients, hypertension, cholesterol, angina, made treatment choice as far as referring for cardiac catheterization via the phone. And so, yes, we're used to feeling that you have more benefit or it's a higher yield visit if you can physically put a stethoscope on a patient. But for majority of patients, that component of the physical exam really does not change my decision making that much for majority of patients. Of course, physical exam, there's a benefit to it, but telehealth is proving that we can make a lot of treatment decisions via phone or with e-visit.
I would say that's absolutely consistent from what we hear from a lot of cardiologists.
Thank you so much. We're out of time for this session, but if you, to the participants, if you continue to submit your questions, and if we can't answer them, we'll send them to the presenters to follow up. Thank you, Dr. Jean, and thank you, Ryan, for your great presentations. I learned a lot.
Thank you.
Okay, now we're going to turn it over to Dr. Deborah Crabb, Professor of Medicine at Temple University Hospital. She'll be presenting on narrowing the gap in cardiovascular disease disparities for the nation's most vulnerable women.
Okay, can you guys hear me?
Yes, we can.
Okay, hi to everybody out in virtual land. My slides are going to come up in a second. There I am. Okay. It's my pleasure to be with you this afternoon, and I'm going to kind of give you a talk on two areas that are very important to me. First of all, I'm going to give you an overview of my view with my life experience as well as with what's out there in the literature about this particular unique population that I take care of, which are low income, low resourced women, and how I think we need to start narrowing that gap. So how do I advance the slides? Any, let's see, will it advance? Start mouse. Okay, my slides aren't advancing. There we go. Okay, I have no conflicts to report. Okay, in order to talk about vulnerable populations and some of the issues that we do see in this particular population of women that I take care of, I think we have to go back to some basic definitions. And so I've included here how the definition of health has changed and should change, and how it's changed basically since the mid-40s. And we have the World Health Organization to thank for that. After World War II, it became increasingly evident to the world that we needed to have national healthcare systems to help residents and citizens in various countries deal with health. And the World Health Organization started to look at this and developed in 1946. It developed a charter with its preamble that really talks about some key principles to health. You know, when we're in medical school or nursing school, whichever the case may be, our definitions of health were different. You know, health, when I was in medical school, is the absence of disease. But that's only one aspect of health. And I think the World Health Organization helped to bring other definitions into our firmament, into our discussion. The preamble states certain key principles that are related to health. One is that health is a fundamental right for all people, regardless of their race, their economics, their social standing or social condition or political beliefs. And two, that the governments have responsibility for their citizens' health. And they have to help and help them achieve this through the provision of adequate health and social resources. And three, health is a fundamental to peace and security. So my health does matter to the rest of the world, or the health of vulnerable women does matter to the rest of the world. And this concept, I think, started with the World Health Organization. They started to work on this definition, and it evolved over years. And by the 1970s, they started to have the concept of health for all. And they wanted to achieve this by 2000. And they held a series of really key meetings that were globally focused, and multiple countries attended. One of them is the Alma Mater Declaration that came out in the late 1970s. It included 22 recommendations regarding how they would achieve this goal. And of the main task for the main statement that came out of the Alma Ata is that governments and the whole world community needs to attain health for all, a level of health that allows them to lead socially and economically productive lives. But by the 1980s, they started to realize that this was going to be a very difficult task. There were countries that were better off and able to handle some of the economic and social issues around attainment of health for all, and there were other countries that weren't able to do that. And so the Ottawa Charter came out and started to define what some of these prerequisites needed to be. And they kind of gave a more global picture about education, income, a stable ecosystem. And all of these things lead to or help people to maintain healthy lives, or the definition of health as they have identified it. So this is a really important concept, that health is not just about not having a disease. It's about having a lifestyle, or being able to be in an environment that promotes your health, and that it has more than just a medical definition. And the absence of an equity, which we point out here, is very linked to this, because we know that the social determinants of health, the living conditions that people find themselves, where they work, they live, and how they go on about their daily activities, determine in part your health. And the lack of good living conditions, the lack of good housing, and other types of social determinants is a problem, and therefore allows for inequities. So health equity is tied very closely to the concept of social justice and the principles of distributive justice, equal access, equal distribution of services, goods, and resources to all. And it's defined as the absence of systematic disparities in health or major social determinants of health between those who are socially disadvantaged and those who are advantaged. So there's a health disparity outcome that we're all aware of between African American women and the remainder of the female population. And when we look at curves like this, where we look at the number of deaths per 100,000, you can see that African Americans from a cardiovascular cause have the distinction of having a big disparity here and a higher death rate. And the question is, what is the relationship to what I've just said to that disparity? Well, I work in a location where I see the disproportionate distribution of resources and poor social and living conditions, and its impact on cardiovascular disease. And we know now that the social determinants of health, or the health which leads to a health of a community, that as physicians, we focus on the clinical care that we give, things like access to care and quality of care. But in reality, that only really attributes to 20% of the health of a community. all these other social factors play a really big role, such as health behaviors, their socioeconomic situation and status and factors, and their physical environment. And so as physicians, we're really only addressing a very, very small piece of what really impacts our health. So here's where I practice. And for those of you who may practice in different environments, you might find this very interesting. But I've been working at Temple University for a number of years. And Temple University is in Philadelphia. It's in the northern section of the city. And it resides in the zip code 19140. If you live in the general area of North Philadelphia, which if you can see on your, let's see if I can find 19132, which is just below the Temple University Hospital. This whole section here is considered kind of North Philadelphia. You have about a 20-year difference in your life expectancy than if you happen to live in zip code 19106, which is the middle class to upper class section of the city, or the Rittenhouse Square section of the city. And when I tell you about the environment for which our hospital sits and the residents that reside in that hospital area or catchment area have to deal with, you'll understand why. So, little about North Philadelphia demographics. Temple University Hospital is an academic university hospital. It is the major provider of care for the underserved population here in North Philadelphia. We give a lot of charity care away because of our population. About 85% of our patients either are covered by government insurance programs, either Medicaid or Medicare. And when we went to that population and we asked them about their health statistics, it was very interesting. When we looked at self-reported health status, which is one of the major indicators of population health, Temple University's patients in that service area, 70% said their health was excellent. However, there was a sizable percentage of patients, almost 30% of the population, that said that they were suffering from very poor or failing health. This percentage is much higher than other regions in the city. And I gave you some statistics for comparison. About 17% statewide give that. We sit in Philadelphia, which is in Philadelphia County. For the county, it's about 23%. According to the Philadelphia Department of Health, North Philadelphia has the poorest health indicators for a location. It has high unemployment and poverty. About 44% of my patients and residents live in poverty. They have a high rate of childhood obesity. There's a high rate of premature death, what we'll talk about in a minute. There is a higher rate of early death. My slides left on me automatically. If you look at Temple University Hospital, the community is made up about 54% women and 46% men. The patients that we serve are predominantly African American. We have rising amounts of individuals who identify from the Latino population. Used to be that was about 15–17% of our population. Now it's rising to 25%, very similar to what we're seeing nationally. And about 17% of them are Caucasian. We have large amounts of hypertension in our population. About 43% of the women report hypertension, and about 12.5% of them have never had their blood pressure checked. So we have people walking around here in North Philadelphia where we have a lot of prevalence of hypertension, and they don't even know that they have it, 12.5%. When the community was queried about health and health issues, they requested access to training on diet. This is advancing on its own, sorry. They asked for training on information, on diet, exercise, and whatnot. Unfortunately, for the most part, thank you. For the most part, that has been a difficult thing for most of the hospitals. We're not the only hospital in North Philadelphia, but for most of the hospitals to provide, because most safety net hospitals like Temple University have very narrow margins. And so having excess resources to do and go out to the community is a challenge, although one we have taken on as a health system to some degree, and also through the help of things like Women Heart. So when we look at the social determinants of health for my community, we know that it's pretty poor. Their living conditions are poor. There's high poverty. There's high amount of unemployment. There's a lot of cardiovascular disease risk factors. And we see that these factors play a role in the health, but we also know that if we can impact these things, we can get a benefit in the area of cardiovascular disease. And in a way, it's an indirect way of having improvement in outcomes. Income, a 10K increase in the median income of a neighborhood has been known or shown to reduce cardiovascular mortality by 10%. We know patients who have better education tend to have less in terms of, they manage their cardiovascular disease risk factors better. Those that don't, those who have a low level of education have a greater number of cardiovascular disease risk factors. We know that employment status, the lack of a job, is associated with an increase in cardiovascular disease burden. And we know that environmental factors have associated with a higher incidence of coronary disease. So I like to bring people through and say, well, what if you were patient 1 in zip code 19132 or 19140, and you were patient 2 in zip code 19106? How would your life be different? And how would your health be different? And that's what this slide basically shows. The person who has not only has a disadvantage, tends to have lower education, at least a lower level of education attained. They may have difficulties in health insurance coverage or access to care. They may have poor health literacy, which is really a problem in North Philadelphia, and particularly for our women, which I'll point out in a minute. They also tend to have a problem with trusting doctors, healthcare systems. They don't understand the meds they're on. They tend not to therefore adhere to the meds. Whereas the person who lives in zip code 19106, they have access to healthy foods. So they may be able to manage any of risk factors that they have inherited better. They certainly can manage their diet better. They have more employment opportunities. They live in a neighborhood that's safe, so they have access to walking trails and places to exercise. They may have less health, life stress, and therefore one could estimate that can lead to at least a 4.4 year difference in their survival. So we know that the majority of lives gained are because of lower cardiovascular disease rates. And this study basically showing that the reduction in the death from cardiovascular disease will give you an increase in your life expectancy of about 5 years. So what happens in North Philadelphia? What's the backdrop that I have to practice on? It's that backdrop of disparity in social access to various resources and having excess poverty in the community and lack of healthy spaces. And this is a map taken from the Philadelphia Health District, actually the Department of Health. And again, here's North Philadelphia. Again, Temple sits right about here. And when we take that map and we superimpose the cardiovascular disease mortality rates for Philadelphia, you'll see right here in this zip code, right in here, in that area where we were talking, the lower North Philadelphia section, it has the highest cardiovascular premature death rates in the city. So everything that I've been saying really plays in to the poor outcome for this patient population and is a challenge to trying to care for them. So where are the issues that I see on a daily basis that I try to tackle? When I was a junior faculty member, it took me about a year, 6 months to a year, to realize that me giving somebody evidence-based medicine therapy in this population was only a tip of the iceberg. I had to get my women to take it. I had to get them to understand why they needed to take it. And I had to do education and try to improve their health literacy around cardiovascular disease. So awareness is a really important thing. And on a regular basis, having come up the Broad Street for many, many years now, I can tell you it is riddled with fast food, unhealthy foods. I probably pass about 5 to 6 different fast food joints. Dunkin' Donuts is pretty popular out here. But I do not pass the Salads Works, a Honey Grow, a Fresh Food Market. In 2008, during the Obama era, Michelle Obama came to North Philadelphia. And why? Because she was at the opening ceremonies for our first fresh grocery store that sits right in that community with the high premature cardiovascular death rates. That was in 2008. So you can see we're really behind in this population. So awareness is really important. And I know that many of you may know the wonderful work that Dr. Mosca did over the years. She does have some additional information after this, but I basically just, kind of reiterate, that there's been improvements in women's awareness of cardiovascular disease risk. This particular slide only goes to 2009. It's increased since then, it's narrowing off. But in the African American and Latino community, we're not getting the same amount of understanding or improvement in cardiovascular disease awareness as a major health concern. Her work also showed promoters and inhibitors of women who that are related to women that actually help them seek a healthy lifestyle. And I always found this work very interesting because once a woman understood that she was at risk, it seemed as though they did something about it. And that is a really powerful thing because in North Philadelphia, we don't have the opportunity of doing a lot of health education, as I stated. But in North Philadelphia, the lack of awareness is incredibly poor. This is some data that we did many years ago, just asking women and just trying to find out, is this the same thing that we see nationally that we see in North Philadelphia? What is the awareness of our women? And what we found is that when we surveyed the community, we found that we had a large group of women who were at risk for their first heart attack, and that those who perceived their risk were much more likely to be proactive with their health. The African American women, once they knew they had a cardiovascular aspect, they were more likely to go to a cardiologist. This is very, very important. However, they don't find out that they have a problem till they have their first heart attack. There's a very small percentage of women who were ever counseled about heart medications in the population when the survey was taken. There were more women, African American women compared to Caucasian women, who actually had a heart attack in this population. And only 14% of the women who actually had a heart attack still recognized that it was a heart disease. So there's a huge opportunity in this population to make an impact. They should be able to do this before they have a heart attack. It shouldn't be the heart attack that prompts them to come to the cardiologist. So increasing awareness is very, very important because it helps women to start to seek methods to decrease their risk, to become involved in therapeutic lifestyle changes. I think that that's also true in a community like the group of women that I take care of. but it requires intense commitments to educating them. And really, how should that education be undertaken? I personally think it's unethical now in my practice to not educate women, because it's so important. Once they realize that they actually have a problem, they will seek additional care. But how should that awareness be disseminated in the community? And where are the resources and funds to do that? There's a lot of obstacles to taking care of this vulnerable population. Because of COVID-19 now, I'm seeing this even more. We're having people who are very fearful now of the healthcare system and contracting coronavirus. So that does create some delays. They're more or less likely to be counseled on risk factor control, particularly in this population. They don't get cardiac rehab. Cardiac rehab is really hard for us to actually get them to go, because we no longer have a cardiac rehab program on site at Temple. We had one, but it was closed. So the only cardiac rehab I can send anyone to is at a campus that's in the suburbs. And my ladies will have to take 2 and 3 buses to get there. And of course, low adherence to medications. So the way I see it, there's a huge problem on both sides. There's system failures because we're unable to have patients who can advocate for themselves, and therefore they lack the insight. We have stress on the system because physicians don't have the time to do this kind of work in the office, although they may be inclined to. And they have limited education on the benefit of meds and treatment interventions and evidence-based guidelines. And this, in my observation, is part of the problem, and it needs to at least be addressed. I suspect that for women, it will be a comprehensive program or a comprehensive approach that deals with this, along with care for medicines, research on effective therapies in their subgroups and groups. But we have to start with informing the patients themselves about what they can do to help themselves out and to take care of themselves when they do have cardiovascular disease risk factors or cardiovascular disease. We know also that physicians on a whole, this is work from Dr. Barry Mertz, about the knowledge and attitudes of physicians on a whole on how to care for women. There seems to be a gap there. This work that she did was a survey that looked at primary care physicians and cardiologists. And I bring this slide in here to basically say that, 22% of primary care versus 42% of cardiologists felt well prepared to take care of the issues that are unique to women with regards to cardiovascular illness. And this is a huge problem. So we have to correct that problem by educating physicians, and not only our current practicing physicians, but our future physicians. And I think over the years, this is getting a little bit less of a priority, at least I'm observing. So when she looks at, how do we solve these problems? How do we approach them? What should we do? We need to not only raise awareness. I'm of opinion that North Philadelphia deserves its own focused cardiovascular disease prevention initiative. It needs a cardiovascular equity program that encompasses women and deals with the racial and ethnic disparities that are riddling and causing infirmity in our neighborhood. We also need to destigmatize, according to Dr. Mertz, and stop stereotyping, counteract some of the stereotypes about having cardiovascular disease. And we need to invest in physician education and research. I have another slide, hold on. So in my community, I can tell you that there's a lot of challenges with taking care of these patients and these women, but there's also a lot of reward, because when you do something in North Philadelphia, when you save a life, I'm convinced the angels sing, because you've done a huge, huge, huge task because it's so difficult to take care of them. Low income and minority women tend to be the least educated on heart disease prevention, despite having more heart disease and more risk factors. And they absolutely need this information. North Philadelphia has the highest heart disease rates in the city of Philadelphia. And we're not going to be able to handle that or deal with that or have those rates come down by just giving acute care. It's just not going to happen. And a pitch here for clinical trial work also that needs to be done in this population. As you well know, women are underrepresented in clinical trials, but African Americans are also underrepresented. And it creates a huge disparity in the efficacy of treatments that are developed. And this is because of mistrust over the years, lack of education on the importance of research, and a low number of minority researchers that can help bridge that gap and explain to the population and garnish that trust to participate in needed research. I have a little bit here on the bottom of the slide about the most famous problematic clinical study, the Tuskegee syphilis study, where inmates were injected with syphilis and did not know about this. And it creates, every once in a while, it gets out into the public. This happened many years ago in the 50s and 60s. And it gets out into the firmament, and again, the mistrust comes along. I can say that in this population I've served in, they can and will participate in clinical studies. We have been a site for Graft Heart Failure 2, a registry study, looking at some of the genetic markers associated with benefit and vital. And we were able to enroll subjects here, both men and women. We've also been participated in another study on hypertension here, where we were able to enroll people. So there is a lot of room for improvement in getting this particular group and women, particularly in clinical studies, but it's going to take a comprehensive approach in which to do this, and it's going to take patient involvement and patient education. So I'm going to briefly say, I have maybe 3 more minutes. There's been I have a call for enhanced public awareness of heart disease in North Philadelphia women. It's imperative. And I'm very grateful to Women Heart, because Women Heart has allowed us to start the work in that area. And as you all know, you guys are a great organization. You're the leading voice of 48 million American women. And I just wanted to share with you some of the things we've been able to do because of your wonderful generosity and the grant that you gave us. This on the left of your screen is the press release that I put out into on behalf of the health system when we received our grant. That press release got picked up by the largest African-American newspaper in Philadelphia. So again, that became news. We were able to start to go out to the community and build on what I've already been doing for years. And we were able to obtain 2 wonderful volunteers and pictured with me here at our News Digest article. With those volunteers, we've been able to work on our peer support groups. And this whole entire plug and play alliance needs to be developed at Temple for this community, because these women need to have the information, and it needs to get beyond the walls of Temple and get into the community where it can be digested and where people can actually start to think about their cardiovascular disease risks. Because of Women Heart, we've been able to do our peer support group. And this is our typical display that we have here. Before pre-COVID, we have out into our lobby to sign women up and to give them out our famous red bags of courage. And of course, Diane here in our clinic space, which these bags are hot commodities at Temple, and the women really appreciated it. and we were able to kind of get them to come to some of our peer support meetings. Challenges still exist. We have a challenge with transportation for women coming here. Some of them had to take buses to get here. Not many of them were driving. And the cost of that transportation was sometimes limiting for them. We have some problems with access to telephone and getting them their email addresses and getting a good list. So a number of different challenges, but I'm very hopeful that the virtual format will actually be very helpful for us. My experience with clinic, at the very least, they can do a telephone encounter and they're very accepting of that. And so we will be working our virtual connections with this community to continue the work. Just a little bit of our outreach here. First, our community partner, one of our community partners is Triumph Baptist Church, who sponsored us. And this is our first Women Heart at that area. I've been able to incorporate this into the education of the house staff. And so for the first time this year, we did our first age-appropriate cardiovascular disease prevention talk at Triumph Baptist. Right here, you can see that's my medical students, fourth-year medical students have been developing those lectures as part of their requirement for their women's health elective. And we've been going out to the community and dispersing those lectures. We've also gotten junior faculty involved. And so our work, we hope, will continue. We're going to go on with virtual visits and virtual peer support meetings. And we're hopeful that we'll be able to continue to do the work and grow this for what I think is a vital part of what needs to happen here at Temple. I think that's my last slide. So in summary, we need a coordinated approach to take care of vulnerable women, starting not only with their evidence-based medicines, but also starting very much with educating them and getting them savvy on self-care, heart disease risk factors, and prevention. We need to educate our providers. That's the next phase I'd like to work on as we move forward with this initiative. We need to explore this whole virtual area. I think that this, for this community, potentially with the correct resources, this could help get over some of these obstacles we have with transportation and not like. We need to educate them on the participation of clinical trials, particularly in this period where we're seeing racial disparities and ethnic disparities play out on the world stage. And of course, as good stewards of medicine, we need to continue to practice good medicine and provide evidence-based treatments to our patients, particularly our women at risk. I think that's my last slide. Thanks for your attention.
Thank you, Dr. Crabb. We just have a few questions before we go into break. Does the Health Department of Philadelphia, do they provide any type of support for your women patients that need assistance to be transported to cardiac rehab in the suburbs?
So, no, I have not been able to get any resources in that regard. So they do have paratransit that will bring them to their doctor visits. And so we've been able to do that, but I've not been able to, or haven't really approached them about, going to rehab. Now, the hospital does have something that's starting in one of their affiliates, so we'll see how that goes. But traditionally, I haven't really been successful at getting a lot of cardiac rehab.
Okay. And how often does your support group meet virtually?
Well, we haven't started the virtual yet because we've kind of been catching up from COVID, but we were meeting in person once monthly.
Okay. And if someone wants additional information on how to join your hospital's group, what would you recommend to them?
Well, we had on our website, they could go to the Temple website, the university website, and find an email where they can email. So it's www.temple, if you look at under Temple Heart and Vascular Institute and you write peer support, you will have, they can email us if they're interested in that. We also, pre-COVID, were doing a lot of in-hospital brochures and flyers. Now that COVID is over, we're working, I actually have gotten a little bit of resources to work on a separate website so that they can go to the website for Philadelphia, since we are the only Women Heart chapter in Philadelphia.
Okay. Let's see if we have any.
Oh, also, I point out they can also find us on the Women Heart website as well.
Okay.
If they go to Women Heart and they're looking for support in Philadelphia, we're listed there as well.
Okay. And let's see if we have one more. I think that's all that we have. So we'll go ahead and wrap to break. Thank you, Dr. Crabb. We really appreciate it.
Thank you. I hope you enjoyed the talk. Have a great rest of the meeting.
You too.
Hi, welcome back. We're going to take a short break. And I'm going to leave you with this small commercial so that as you take a break, please return back at about 2:55 and we'll start with the second half of our conference today.
I'm a survivor.
I'm a survivor.
I'm in my 50s and I had a stroke. My mom had a heart attack. I didn't know high cholesterol is related to heart disease.
Or that I have a genetic disorder that causes high cholesterol.
I really thought I was too young to worry about it. I just assumed everyone had high cholesterol these days. Good cholesterol, bad cholesterol, I never understood the difference.
I eat pretty healthy, have my oatmeal every morning.
It never worried me. I carried my lab script in my purse for a year. Never got it done. I hated having a fast first. I never had time.
I never made time.
I make time now. I pay attention now. I pay attention now. I pay attention to my cholesterol now.
Will you?
1 in 2 women has high cholesterol or borderline high cholesterol, putting them at risk for heart disease. For a free tool to track your cholesterol, go to womenheart.org/cholesterol. I'm a survivor. Tengo 50 años y tuve un derrame. Mi mamá tuvo un ataque cardíaco. Yo no sabía que el alto colesterol es relacionado a las enfermedades cardíacas o que hay un trastorno genético que puede causar el colesterol alto. No presté atención. Yo sí presto atención ahora. ¿Y tú lo vas a hacer? 1 de cada 2 mujeres tiene el colesterol alto. Para un medidor de colesterol gratis, visita womenheart.org/colesterol.
Hello, everybody. Thank you and welcome back. As you saw, we had planned a virtual discussion to have a conversation with the NHA member attendees, but the conference has been going so well with a lot of information, we didn't want to rush the presenters. So following the conference, we'll send you a survey along with some other resources with questions that we're asking so that we can develop more programming, support, for women live with heart disease, as well as our hospital members. So please look forward to that in the future. We will tackle that in. So now I'm going to turn it back over to Morgan Chandler, who will go over our next set of presentations.
Okay, so our next presentation will be heart disease and mental health. Our first presenter will be Kelly Davis. She's the Director of Peer Advocacy, Supports, and Services at Mental Health America, where she works on the expansion of peer support and young adult leadership. Accompanying her is Dr. Hisla Bates, who is a board-certified Harvard-trained pediatric and adult psychiatrist with over 20 years of experience in the diagnosis and treatment of severe mental illness and managed care. Welcome to you both.
Awesome. Thanks so much, Morgan. Great. Awesome. Well, I'm Kelly. I'm really grateful to be here with you all today. And really want to thank Women Heart for letting me come share with you all, but also just for really emphasizing and making sure to include mental health in the conversation. I think, there's still a large stigma around mental health, around reaching out for support. And I think really having these conversations, we're not only openly talking about mental health challenges, but also sharing information about resources and what people can do. And I think Dr. Bates' presentation is going to be really awesome as well on this topic. So just to get started, so I work at MHA and I really represent the consumer perspective. So we work directly as a representative for consumer or people who are receiving services communities. Awesome. So as an overview, so the three things that I'll cover during the next 15 minutes is first, review the mental health impacts of heart disease for women, specifically explore a virtual resource for tracking and learning about mental health, and then discuss preferences and opportunities for mental health support. So just to get started, mental health and heart disease. Mental health and heart disease, particularly depression, I think is talked about pretty often. According to the NIH, 20 to 30% of people who are cardiac patients are dealing with depression. And it's really interesting what the research shows. So on one end, obviously the experience of heart disease can lead to depression in folks, but actually on the reverse side, research also shows that women with depression are more likely to develop heart disease. And I think that that's a really interesting kind of dynamic of either, you were set up as somebody who's been struggling with depression, that increases your likelihood, but also the experience of heart disease and what the impact on your life and the different things that can happen to you as a result of that can also increase your likelihood of experiencing depression. I think another topic that is really important that isn't talked about as much is the impact of trauma. So what we also know is trauma and post-traumatic stress disorder increases the likelihood of heart attack and stroke. So I'm not sure if folks are familiar, there's some really foundational research on childhood trauma. It's called the Adverse Childhood Experiences Study. And what it found was that for youth or children experiencing childhood trauma, whether that is divorce in the house, whether that's having a parent who's incarcerated, experiencing abuse or neglect, actually really largely increases your likelihood of developing different health challenges over time. So I think a lot of people, intuitively think about the mental health impacts of trauma and how those struggles and experiences could lead to different challenges later on, but there's also a lot of research that shows that there's actually a physical impact. So folks who experience childhood trauma during their early years, later on in life are more likely to experience things like diabetes, and heart disease and like COPD and a lot of different things. And that stands true for heart disease as well. So women with PTSD are actually 60% more likely to experience heart attack or stroke. And women with a general trauma history who might not meet diagnostic criteria for post-traumatic stress disorder are also 45% more likely to experience heart disease. And, you know, I think separate from that, yes, there's the childhood experiences during your formative years that can impact your well-being and health. There's things that can happen to you later on in life, but I think it's also important to mention that trauma can also be experienced as a result of heart attacks or cardiac events. So I think that, yes, you're more similar to depression, right? You're more likely to experience heart disease if you have a history of trauma, but that experience with heart disease can be traumatic as well. So to talk about a resource that MHA offers in particular, is we have an online mental health screening program. So our online screening program launched in 2014, and since we've had over 5.5, slightly updated these, 5.5 million folks come and take these screens. And they're, as you can see on the screen, they're across common mental health conditions, so depression, anxiety, bipolar disorder, psychosis. We have screens for parents and for youth. And these are free, anonymous online screens. So most of the folks who come to us are actually people who are Googling bipolar test, am I depressed, and things like that. And the screens that you can see in parentheses, the little combination of letters and numbers. And that's just a reference to the fact that these are all clinically validated screens. So they're not kind of just random tests, but they're actually the same questions that your psychiatrist might ask you or your primary care physician might ask you, and they're all research based, whether they are things that are commonly used like the PHQ-9 or the GAD-7 for anxiety, or some of the other screens we offer, like the parent or youth screen, where we've actually partnered with research institutions and focused on those. So as I mentioned, the screens are anonymous and free online, and I definitely encourage people to check those out. They're a really great way to monitor your well-being and check in on yourself, or if you're worried about someone else, it has the option when you get your results to share with someone else. So if you are uncomfortable having that conversation, we do have information that you can share with your doctor, with the people in your life, with your family, to help you start that conversation. But while the data is anonymous, we have a number of partners who we work with on the screening program, and Women Heart is actually one of our partners. So what that means is that we provide a screening link for folks, and through that link, we do de-identify the data, right? We're not tracking people's names, we're not sharing any personal information, but through the data, we are able to analyze the screening results for folks who came to us through specific organizations or partners or links, whether that's Women Heart, whether that's a Facebook link, a Reddit thread. We get all kinds of folks referring to us. So you can see on the screen a breakdown of what folks are checking out for themselves. So the number of folks who are in the screening, so it was 355 people from the Women Heart link actually took our mental health screens. And it's pretty similar to what we see across our broader screening data that's not specifically from Women Heart, which is most people are coming looking for support with depression, followed by anxiety. And then it kind of varies in terms of bipolar disorder, PTSD, and then we have some, as you can see, lower on alcohol and substance use disorder, parent and psychosis screen. But the amount and the surveys and the percentages on this chart pretty closely mirrors what we see in the general population. But the next question, or the next slide, I think is actually pretty interesting. And it is a breakdown of the different results. So while the breakdown in terms of the surveys or the screens that folks from this link took really mirrors what we see in the general population, I think the results were really interesting. So if you can check it out, you know, the depression, which is typically our biggest screen, and it was in this population as well. It's actually decently spread out for mild depression, minimal depression, moderate, moderately severe, and severe. Those are, you know, broken down by how you score on the screen. But I think what really stood out for us, that as I mentioned earlier, kind of challenged a lot of, you know, maybe not for people who specialize in heart disease and work in this field and work in this advocacy, but I think the mainstream conversation around heart disease is really often focused on depression. And as you can see on the page, the actual, you know, the depression results that we got are actually higher representation. So people, the spread for results for the general population, actually more people typically are screening with moderate, moderately severe, or severe depression. It's pretty spread out from folks from Women Heart, but I think the PTSD results are really powerful, and that there was such a high rate of folks who are screening positive. And, you know, I had a conversation with Dr. Bates about this. It's really interesting. We actually can't tell because we're not asking this question in the way we're collecting the information, but we really, it's unclear at this point how much of it is from, you know, something like experiencing an adverse childhood experiences versus experiencing trauma kind of later on or in the, you know, in the time between your childhood and when you're taking the screen, or actually from your experience with heart disease. So I think that, you know, there's more to be seen, and I think that's a really interesting conversation to have. And I think that it's also important for folks in looking for resources is an understanding of the importance of clinicians or providers who understand the impact of trauma and who understand the impact of, you know, developmental trauma, but also the trauma that you might be, or an individual might be experiencing as a result of their current circumstances. I think it also speaks to the importance of not just mental health clinicians, but all medical professionals in understanding the impact of trauma. If you're working with folks who, I think a lot of times in any health condition, the importance of mental health is kind of swept under the rug, or it's not something that folks think is their job to talk about. But as we can see in here, as we can see with the research, that like the prevalence of trauma is so high for folks, that it's really important for providers to have an understanding of trauma and the impact of trauma and how that might be affecting people in their lives, and how to refer them to, how to approach people in a trauma-informed way. So that really means, you know, emphasizing people's voice and choice in their treatment and services, as opposed to a more disempowering way of telling people, okay, this is the information, this is what you have to do, see ya. But really partnering with and giving people voice and choice in their care, I think is really important generally, but specifically from what we see for folks who have a lot of experience with trauma. It can be really healing and also just more engaging to be approached in that way. So after the screen, so yes, we provide information, folks can check in on their mental health, but we also have a screening to supports platform. So this is based on what folks over the years have told us that they wanted as a follow-up to screening. So it's really broken down into 4 compartments. One is learn. One is learning more. So it's information about treatment, information about different mental health conditions. And what's really exciting about our resources, I think, is that we do a really good job writing in plain language. So it is not written like you're reading WebMD. It's written like I'm sitting and talking to you as somebody who lives with PTSD. Is like, this is what it's like. And this is the language that people really use to talk about their own experiences. We combine short articles with podcasts is something that we do a lot now to just make the make the information easier and more accessible. We also provide do-it-yourself self-help tools. So different things that folks, who might not be working with a clinician, might not be interested in working with the clinician, or might want to just have some things that they can practice on their own. So we provide those. We provide referrals to treatment, so information on how to find clinicians in your area, and navigating all of the complications that come with finding clinicians, that I'll kind of jump over in the next slide. And then connection. One of the biggest things, I work in peer advocacy, the power of connecting with other people who share your experience and your stories, and the hope and the support that you can receive from that is really important. So at MHA, we really emphasize opportunities to connect with others with shared experiences as a means to support and promote mental health and well-being. And as a last kind of slide about looking for help and resources for finding help. So we have the screening program, we have the screening to supports platform for people who are just kind of, interested in exploring, but we also have a finding help page that's really guided by where folks are in their journey. So if you see on the left, it goes all the way from, I don't have anything I'm too concerned about, I'm just trying to stay well, to, I'm in crisis, I'm worried, I'm slowly having a hard time keeping up with work, I'm having a hard time, staying in touch with friends. We really have resources that are organized by where somebody might be in their struggle or where they're doing well. And we provide information for folks who are looking help for themselves, for someone else, information about like what folks practically need to know. So treatment, providers, insurance can be incredibly complicated to navigate. So what you need to know about your insurance, and also what local resources might be available to you. We also, in line with our kind of process of, or philosophy of like being really, really accessible, we do a lot about what to expect when you're looking for services. I think as anybody who's struggled with any, as I mentioned, I live with PTSD and bipolar disorder, but dealing with any kind of health struggle, I think a lot of times it's so isolating. So we do try to create resources that make it at least easier to know what to expect and what'll happen at different points and what'll be asked of you, how to advocate for yourself and that kind of thing. And we also provide a section on frequently asked questions that people may have when they're struggling with their mental health or just looking for help and resources. So I shared a lot of information with you, but really, wanted to just acknowledge the importance of mental health generally, but specifically for folks for women with heart disease, whether that's things that providers and doctors should consider, or family members should consider, or people themselves who are living with these conditions, and some resources around, some of the things that MHA as an advocacy organization offers. So on the screen, I'm at my time. On the screen, you can see my contact information. I hope this was valuable and of service to you all in some way. Please feel free to reach out to me if you have any questions, or if I can provide any additional information. Thanks.
Okay, thank you, Kelly. We'll now turn it over to Dr. Bates.
Hello. Hello, everyone. Hi, my name is Dr. Isla Bates, and I'm a psychiatrist in private practice in New York City. I'm also an artist, a SCAD survivor, and a women heart champion. So I have a unique perspective on being both a physician and a heart attack survivor. And my talk is entitled Mind Your Mood, Mind Your Heart, Mental Wellness and Cardiac Disease. Next slide, please. Okay, I have no disclosures. And next slide. Mental wellness versus our objectives, mental wellness versus mental illness. We're going to talk about that. The emotions after a cardiac event, PTSD versus PTG. I'm not sure how many people have heard of PTG, optimism, and heart disease. So when we hear the term mental illness, we often think, what is wrong with the person or the patient? What brings you to see a psychiatrist? Usually it's because something isn't going well. And frequently we associate mental illness with something bad. And we focus on what's broken and we try to fix it. But what if we didn't see individuals as having disabilities, but rather we focused on their ability? Instead of, we should focus on mental wellness, what's going well in their lives, and let's try and amplify that so that they can feel empowered and thrive. So what does mental wellness after a cardiac event look like? After a heart attack, most patients I can identify feel very broken. And your brokenness is further amplified by the damage that's done to your heart or some of the medical information that you actually get. And, you know, doctors will come and they'll tell you, you have 40% occlusion, but no one's talking about patency. Patients are expected to suffer from depression and anxiety after a cardiac event. That's true. But I think it's really important that we normalize some of those feelings. People have to adjust to the news that they're reaching a new normal. As a cardiac patient, there is a grieving process that one goes through, and I liken it to Elizabeth Kubler-Ross's stages of grief. Her stages of grief are denial, anger, bargaining, depression, and acceptance. And there is some overlap there. And I think that there are stages of grief where, or shock, there's shock that comes to the individual that this event has happened to them. There is some grief because you know that you're going to have to adjust to a new normal. There's eventually acceptance and hope, hopefully. So, mental wellness after a cardiac event, it's really important to give patients some reassurance that what they're feeling is within the normal realm, that it's not going to last forever, and that you really need to give them hope. Next slide, please. So what produces anxiety is uncertainty. Uncertainty of another cardiac event, and death looming over the cardiac patient. If something goes wrong with your heart, you realize how close to death you are. And that awareness alone is psychologically impactful and pretty scary. So it's really important to talk about connection and relationships when it comes to heart disease. Our heart is intimately connected to our emotions. If we all know about Takotsubo cardiomyopathy, which is broken heart syndrome, where a section of the heart weakens and balloons out when there's severe loss, or it could be extreme excitement or even public speaking. So knowing that the emotions are tightly connected to our hearts, we need to protect our minds. And in doing so, we are protecting our hearts. And therapy is one way of relieving stress, worry, and anxiety that is going to accompany heart disease, and helping cardiac patients to express their emotions. A lot of cardiac patients will suppress those emotions. And it's very important that you give them resources in which they can relieve some of their underlying anger, anxiety, maybe depression as well. In therapy, we also need to assess our relationships because we know that our relationships also impact our heart. And if you are in a toxic relationship or a loveless relationship, you are more likely to have a cardiac event or a heart attack. And if you have a toxic boss as well, that can also impact your heart. So we can talk a little bit about PTSD versus PTG, and I'm sure some of you know what PTG is and some might not. Next slide, please. Post-traumatic growth is what PTG stands for. And we all know what PTSD is. After a trauma, PTSD or post-traumatic stress disorder can be quite debilitating. But there are some people who experience the same trauma, but yet thrive. And the psychologists Lawrence Calhoun and Richard Tedeschi have studied this and coined the term post-traumatic growth, where someone has a traumatic event in their life, and instead of becoming debilitated, they actually have a greater appreciation for life. They improve their relationships with people, and they show greater resiliency. Another psychologist, Jamie Pennebaker, has studied journaling, and she has looked at spouses who've lost their partner, and when they expressed and felt those emotions, they actually had better health outcomes. Tal Ben-Shahar, who's a mentor of mine, and has coined the term permission to be human, which is very important that we accept our emotions, both the painful and the joyful ones. And actually, in order to feel joy, one also needs to experience pain. So it's not about pushing the negative away and not addressing it. It's actually feeling the pain and allowing yourself to feel the pain that also helps you to feel joy as well. There have been quite a few studies on optimism and heart disease, and this is really interesting because in one study, they took over 300 middle-aged patients who were waiting coronary artery bypass surgery. They did some psychological evaluations on these patients, which looked at optimism. And Marty Seligman at the University of Pennsylvania is a psychologist who studies optimism. And so what they found was the optimists were only half as likely as the pessimists to require rehospitalization. And another study with almost 300 people awaiting angioplasty also showed that the pessimists were 3 times more likely than the optimists to have heart attacks or to require repeat angioplasties or bypass surgery. So I want to talk to you about compassion, because as a physician, oftentimes we don't have compassion for ourselves, and it's difficult to have compassion for other people if you're not taking care of yourself. So it's really important that the staff also be cared for by their hospitals. I think it's really important to talk to patients, especially after a cardiac event, and sitting down with a patient for a minute can feel like 10 minutes to that patient. And if every doctor and nurse would just do that for 1 minute, it could make such a big difference. I remember after my heart attack, having 7 doctors come into the room and stand over my bed and then say, "So what was that story again? Tell us what happened," as if they hadn't heard it the first time. It's so important to listen to patients, to listen to their stories. Within their stories, you will find their diagnoses. I'm also a very strong proponent of the arts and music therapy. Wouldn't it be lovely to have music therapists and art therapists in the room with the cardiac patients, helping them to express those suppressed emotions, which often is accompanying the heart disease? Meditation should be part of the hospitalization, where patients are given resources for meditation. Meditation actually helped me with the chronic pain that accompanied post-SCAD. There are meditation apps like the Breathe app, Headspace, and Calm, which are excellent for teaching patients how to meditate on their own. I really believe that all cardiac patients should have cardiac rehab. I know that's not possible. And my dream would be to see that every cardiac patient have some sort of maintenance, lifetime maintenance, where they have a support group and they can go to cardiac rehab for maintenance. I encourage staff as well as patients to do nature walks, to, if there's a Zen garden in the hospital, to go there and actually meditate, relax, or just sit amongst nature. It's very healing. And I think healthy eating habits should also be part of the hospital stay. One should be educated while in the hospital. Cardiac support groups, extremely important, and patients should be encouraged to find these support groups. And if they can't, there are many groups on Facebook that I myself personally have utilized and have found very helpful. So in summary, I want to say, let's focus on mental wellness. Let's try to let cardiac patients know that there's going to be a period of time where they feel sad, grieving, that there's going to be a period of adjustment. And this adjustment is temporary. It's not lifelong lasting. And that they will eventually feel better, but it is part of the normal course. To find emotional balance in their lives so that they are able to express both positive and negative emotions, very important. And to try and shift their mindset to a more optimistic outlook can actually have a dramatic impact on their wellness. Let patients know that there's such a thing as post-traumatic growth, because knowing that that's a possibility, that not all trauma leads to something negative, that trauma can actually lead to personal growth and well-being. And most importantly, please give patients hope, because hope is going to be life-saving in a lot of ways. And next slide. So I want to thank you all for allowing me to share some of my thoughts about mental wellness with you. And yes, thank you so much for having me.
Thank you both. We'll wait just one more minute to see if any questions come through for the Q&A. Oops. Okay. Doesn't look like, oh, let's see. Okay, I think we have a couple. Okay, it looks like some of our attendees, they really appreciated your, both of your presentations. They said, thank you, it's very informative, and they love the term PTG. It's a great concept.
Yeah, it is.
Okay.
No questions? Oh, no questions at all.
No, it doesn't look like any came through, but thank you both. We really appreciate you participating in this presentation. It was very helpful. Thank you so much.
Thank you. Bye now.
And I will turn it over to Calandra Tibbs.
But apparently I was on mute. So sorry about that. Again, thank you so much, Kelly and Dr. Bates, for your great presentations. The comments coming in were more about the quality and the content, how meaningful it was, and less questions. So again, thank you. Next up, we'll have 2 presentations on serving women heart patients through cardiac rehab. First, we'll have Haley Stolp, who's a public health analyst with IHRC, working for the Division of Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention on Million Hearts. which is a national initiative co-led by the CDC and the Centers for Medicaid and Medicare services to prevent 1 million heart attacks and strokes by 2021. Our second presenter, Dr. Teresa Becky. She's a professor and associate dean of the PhD in PhD in Nursing Science program at the College of Nursing and professor in the Division of Cardiovascular Sciences, College of Medicine at the University of South Florida in Tampa. She's also a member of our Scientific Advisory Council. So now I will turn it over to Haley.
Excellent. Thank you so much. I'm so happy to be here. And really appreciate the previous conversation and the reference to cardiac rehab, which is the topic I'll be talking about today. And do next slide. There we go. So no disclosures, but a disclaimer that my comments are those of my own and not necessarily reflective of the CDC. Okay. Sorry, having trouble with the slides here. Excellent. We'll go back to that. Yep. So premature heart disease. I think many of us have seen similar data showing the decline in mortality over the years, which we're happy to see. In yellow here is the decline in mortality among women. And what I want to bring your attention to is the flattening of that decline that we've seen beginning in 2011. And that's most concerning, seeing the slowing of the mortality rate. And we attribute that largely to the rise in obesity and diabetes and potentially other chronic diseases. But we want to make a big change in increasing that decline. And more than that, ensuring that we're addressing the needs of adult populations. We're actually seeing a rise in mortality. So if you're not familiar with Million Hearts, we're a national initiative co-led by the CDC and CMS to prevent 1 million heart attacks and strokes by 2022. We work across the platform and keeping people healthy in the community, optimizing care in the clinical setting, and improving outcomes for priority populations. We work across federal and state agencies and private organizations. So the platform 1 Million Hearts, we work again in these 3 focus areas. We'll be focusing today primarily on increasing use of cardiac rehab, and that includes engaging patients in the heart healthy behaviors as was previously discussed, and that's in our optimizing care, working with clinical health systems and hospitals, and also improving outcomes for priority populations. That falls in people who have had a heart attack or stroke, but we'll be talking about the heart attack given the qualifier for cardiac rehab. So cardiac rehabilitation, if you're not familiar with it, it's a multidisciplinary approach to apply evidence-based secondary prevention therapies of known benefit to qualifying cardiac patients. It's really a team-based care component, and it's comprehensive in addressing the cardiovascular disease risks for those cardiac patients that are eligible. It generally includes a physician-prescribed exercise, nutritional therapy, counseling, services to improve medication management or compliance, tobacco cessation services, which may be very critical for some of those that are smokers, and then counseling therapy for emotional well-being and stress management, as was previously discussed, a real key component of the cardiac rehab program. It's typically administered over 36 sessions over 12 weeks. And I see my video is having some difficulties, so I might unfortunately freeze the video. There we go. Next slide. So who benefits from cardiac rehab? Well, there's strong evidence of benefit for individuals who have had a heart attack, have stable angina, received a stent or angioplasty, have heart failure with reduced ejection fraction, or have undergone bypass valve or heart-lung transplant surgery. And the insurance for these qualifiers for cardiac rehab is established. Medicare covers it. Of course, there is a cost for the co-payment, but it is widely covered across insurers, less so among Medicaid payers. Next slide. What is the evidence? Reduces all-cause mortality, which is really critical. The benefits of cardiac rehab are comprehensive. as well as addressing the cardiac causes of mortality by 26 to 31%. Reduces hospital admissions less than 12 months post-discharge by 31%, so keeping people out of the hospital after their qualifying event, and then improves functional status, mood, and quality of life. And also more is better, so there's a strong dose response for cardiac rehab, such that the more sessions you attend, the greater the health outcome. And we generally see that clinical threshold of around 25 sessions. How many people are using it? So unfortunately, uptake of cardiac rehab has been relatively poor in our country. It's estimated around 20 to 30% of eligible people are participating in cardiac rehab. And I was engaged in a recent analysis looking at 2016 to 2017 Medicare beneficiaries. We found about 24 participation rate. And only about 26.9% of those completed the cardiac rehab program at 36 sessions. So we have a lot of progress to make. Lower participation rates are seen among people of color, women, elderly, people with comorbidities or low socioeconomic status, and participation varies by qualifying condition or procedure. So we see more patients with PCI getting referred to cardiac rehab than perhaps heart failure, which has the lowest referral rate of about 10%. And significant geographic variations, so we don't see programs in all parts of the country, unfortunately. Next slide. So this is a breakdown of the Medicare analysis that was just completed. We see overall been 24% of those that participated, of eligible patients participated, and we see it here broken down by race ethnicity. And overall, women have a lower participation rate than men. We see a lower completion rate across the board in the dark green. So again, lots of room for improvement. The barriers to cardiac rehab use, many of you are familiar with these. So system level barriers, lack of awareness about the value of cardiac rehab, no clear and consistent communication to patients and families. We've actually heard references of patients sitting in the room and hearing the doctors talk about cardiac rehab, but no consistent communication to the actual patient and their family members, which is really critical, having that referral happen when your family's with you in the office room there, the hospital bed, most likely. Cardiac rehab programs are not integrated into the cardiovascular services, so cardiology is usually a specialty that doesn't always focus on the secondary prevention. Eligible patients are not systematically identified. A lack of automated electronic referral process that can be so key in identifying those patients that are eligible and automating that referral process so that they get that referral in place. And then cardiac program not available in the service area, as mentioned previously. Some patient level barriers as well, logistics of getting to the program, center-based program. So transportation, I know that was mentioned previously, of getting 2 to 3 buses to access a cardiac rehab program could be a huge barrier. Parking at hospitals can be costly sometimes, scheduling the appointment, and then the proximity to the program. Cost sharing, as mentioned, there is largely a co-payment for sessions. So if you're going to all 36 sessions, that co-payment over time can really add up and be a significant barrier for patients to access cardiac rehab, as well as completing responsibilities that might include childcare, work, senior care, and cultural and language issues. So we do see a lower participation rate among Hispanic populations in the United States. I want to point to a key component of how to address these is physicians' endorsement of cardiac rehab. So there's been evidence to suggest that eyeball-to-eyeball conversation with the physician sitting next to the patient and saying, I recommend you do cardiac rehab, can be a huge driver, and that's specifically for women as well. So having that reinforcement and that recommendation from a physician can be a huge influencer in the patient enrollment in cardiac rehab. So in 2016, we released a roadmap to guide the use of cardiac rehab. A big part of that was showing that between 20 and 70% increasing participation from 20 to 70% can save 25,000 lives and prevent 180,000 hospitalizations annually. And this roadmap had some of the key interventions to help drive progress towards that. Since then, the Cardiac Rehab Collaborative has grown. We continue to focus on that 70% target by 2022. We convene on quarterly online meetings. We have about over 400 members, and this includes cardiac rehab program medical directors, managers, the staff. Many public health professionals are engaged in this work, vendors, payers, so a wide variety of multidisciplinary folks from over 190 organizations. And we have a shared action plan from which we operate that has the following 5 objectives: increasing awareness about the value of cardiac rehab, increasing use of best practices, and that extends to referral, enrollment, and participation, building equity in the referral, participation, and program staffing, increasing sustainability, affordability, and accessibility through innovations, and measure and monitoring our progress. There's an email address on here, millionheartscrc@cdc.gov. If you're interested in joining the collaborative, we're happy to have you. Any and all people that are wanting to make a difference in this area are welcome to join. So part of that communications effort, we have a communications toolkit where we host some patient testimonials. We're specifically focusing on women and women of color, given the low participation rates among the US population. So here we have patient testimonials from Jana and Patricia, and I'm happy to say we've previously done one with Annie DeFaso, a big Women Heart champion that's been a huge supporter of our work. And getting this messaging out is part of the effort in increasing uptake. We've had a couple Twitter chats, and I have a website that can be embedded on your website through a syndicated process to help get these messages out. The link to that toolkit is at the bottom of this slide. We also developed the Change Package in partnership with the American Association of Cardiovascular and Pulmonary Rehab, that's AACVPR. The Change Package is a comprehensive set of interventions that hospitals can implement to increase their participation rates. It has specific change ideas or strategies, and then we take it a step further in incorporating tools and resources from hospitals that have implemented those strategies. The Change Package is broken down into these 4 focus areas. Systems change, which is really working with your administration to get a focus and a commitment to increasing cardiac rehab. Referrals is that referral process that's usually in the hospital or the primary care practice. And then the moving to enrollment, participation, and adherence, which is largely in the cardiac rehab program. And I have a huge exclamation point because we often see patients drop out from that referral to enrollment. That's moving them from inpatient largely and getting them discharged into that outpatient setting. And that big jump can be happening more efficiently, more smoothly with standardizing and automatizing the referral process and deploying an inpatient liaison, having a care coordination component. And we are very thrilled to be working with AHRQ and their Take Heart initiative to increase use of these interventions. This is an initiative that was recently launched. It's a 3-year initiative from 2019 to 2022, $6 million. And we have 100 hospitals that are implementing automatizing the referral and then having a care coordination jump. We also have a learning community where hospitals can join together and implement strategies from throughout the Change Package. This is an opportunity to share resources and strategies and best practices. And the learning community is still growing, so there's an opportunity to still join that. There's a link at the bottom. If you click the Join Take Heart, you can join the learning community and be part of those monthly calls to really get some insights into what cardiac rehab programs are doing. And right now, a lot of the communication has been around COVID and what cardiac rehab programs can do to ensure the safety of their programs during the time of the pandemic. And then finally, a resource center where all the training modules from the initiative will be compiled and accessible. A couple new education and training resources to let you be aware about. American College of Cardiology has a physicians webinar series. The International Council of Cardiovascular Prevention and Rehab has also released a new care coordination training portal. And both of these are accredited for some credits for physicians and I believe nurses as well. We're also always looking to capture the new lessons learned and new opportunities, new innovations on how to get more people into cardiac rehab. We encourage those that are on the call today that have some best practices to share with us to send them to the Million Hearts CRC@cdc.gov website or the Take Heart initiative as well. We partner with them on capturing these best practices. American Hospital Association also has a submissions opportunity. It's a Huddle for Care platform to show best practices for referring to cardiac rehab. And then the Million Hearts Hospitals and Health Systems program. This is a recognition program that Million Hearts launched earlier this year, and it has some cardiac rehab components in it. So it's a great menu of strategies and opportunities to incorporate Million Hearts components in hospitals. And again, cardiac rehab is a big part of that. Because we are the CDC, we do want to monitor performance. So we do have a cardiac rehab referral measure that's in the quality payment program with CMS. And then these are a couple of resources from the Change Package on how to access referral data to monitor progress and ensuring that all eligible patients are getting referred appropriately to cardiac rehab. And then to assess cardiac rehab participation, that's really the enrollment and then continued use of cardiac rehab. We have a surveillance methodology that we developed that can be used by cutting and pasting that component into the claims base. And then very recently, HEDIS released a new cardiac rehab measure. So that's an opportunity for payers to get engaged in monitoring cardiac rehab participation. So again, opportunities as a whole on how to build equity in cardiac rehab, automatic referral of care coordination, and again, TakeCard is really the leader in making this happen across hospitals throughout our country. Engaging with care coordinators and patient ambassadors to ensure that people inpatient are appropriately referred and I've given the information to do cardiac rehab, and Women Heart Champions might be an opportunity to access and leverage that resource in your community. I know Annie works with that in Florida. Offering culturally appropriate enabling services. So these are services like non-emergency medical benefits, transportation opportunities. It might be using a social worker and ensuring that that bridge to cardiac rehab is happening. Minimizing obstacles for participation and rewarding participation. These are also strategies from the change package. We've got a wealth of different ways on how you can set up a time schedule that works, a more flexible opportunities for people that are working. And then finally, helping eligible hospital employees. So a lot of times hospitals are the leading employer in their communities. And so ensuring those benefits are available and the flexibility is made available for people to participate. I mentioned earlier that the cardiac rehab is not available everywhere right now. So these are the center-based facilities we have in our country. And if we were to fill all of them to capacity plus 10%, we would only serve about 45% of eligible patients. So that speaks to the need for some innovation models that our next speaker will be talking about. And just before I close out, a couple million hearts and partner resources I want to let you know about. We just launched a communications campaign. So there's some new public service announcements about the importance of going to the hospital. If you have a heart attack or stroke, you'll see them out in the media throughout. And this is a sample of one that we have that was recently came out, but we'll have a whole communications toolkit on the Million Hearts website. I'm really excited to have that communication effort in place. We also recently released our hypertension control change package. This is the second edition. It has a whole new suite of tools on self-measured blood pressure monitoring, chronic kidney disease prevention, and identifying undiagnosed hypertensives. We also recently hosted an SMBP video for pregnant and postpartum women in partnership with the Division for Reproductive Health here at the CDC. So a new resource with some subject matter experts providing guidance on that. And then they released the Pressure Campaign. It's a new campaign targeting Black women to be engaged in their heart health. I think with that, I'll stop and we'll take questions later. Thank you.
Thank you, Haley, for that really wonderful description of cardiac rehab. And so we clearly know the benefits of center-based cardiac rehab. There we go. And these are my disclosures. So we know that traditional center-based cardiac rehab is unquestionably the gold standard for secondary prevention. However, over the last 3 decades, only 10 to 20% of eligible women have attended cardiac rehab, with up to a 56% dropout rate. Ours was the first federally funded study for the effects of a different delivery model for women. The most effective components from the women's perspective were the exclusion of men, the use of group support, and motivational interviewing counseling style. However, it had limited reach because it was a center-based program. So we've heard the cost of center-based cardiac rehab can be prohibitive and transportation and parking challenging. Without health insurance, programs can cost up to $6,000 out of pocket, and even with insurance, patients can endure up to $1,800 in co-payments. Many women work during the day, some dislike mixed-gendered group exercise, or they're caring for loved ones. Programs are costly in terms of buildings and equipment, and they're staff intensive. So despite the many benefits of center-based programs, they can be prescriptive and maybe less conducive to lifelong disease self-management. We still see sex and racial disparities in referral, access, and insurance coverage, and limited hours of operation. The current program structure is often dictated by reimbursement, with greater reimbursement for ECG monitoring that may be unnecessary. Even the criteria for patient eligibility is dictated by reimbursement. Graduation from center-based programs may send the message that completion implies that behavioral improvement is complete. Up to 60% of participants relapse by 6 months, and most of the benefits are lost by 1 year. Some say that our current model of center-based cardiac rehab is financially unsustainable. Moving forward, I think we need to think creatively and use technology for alternative approaches. Models that include home, internet, or community-based programs are needed to provide alternatives to cardiac rehab that are center-based. Emphasizing lifelong health behaviors versus program completion would be beneficial. Cardiac rehab could be transformed to a broader healthy lifestyle program. Alternative models do not need to replace conventional cardiac rehab, but could serve a much larger patient population over an extended duration, well beyond the traditional 12-week window. So home-based cardiac rehab relies on remote coaching with indirect exercise supervision, mostly or entirely out of a traditional cardiac rehab setting. And we have increasing scientific support for home-based cardiac rehab. From this scientific statement from the American Association of Cardiovascular and Pulmonary Rehab, the American Heart Association, and the American College of Cardiology. Home-based programs are much more prevalent in other countries. This statement identifies core components, efficacy, strengths, evidence gaps, and the research necessary to guide the future delivery of home-based cardiac rehab in this country. So what are some of the potential advantages? Well, we could reduce enrollment delays. They can be easily integrated with the patient's regular home routine. We could expand capacity and access. We could provide individually tailored programs, perhaps more easily. We could provide flexible scheduling with minimal travel or transportation barriers. There could be greater privacy while receiving cardiac rehab services, and possibly greater adherence and sustainability. What about the potential disadvantages? Well, in this country, there's lack of reimbursement. There might be less intensive exercise training. There could be less social support and patient accountability. We are seeing some lack of standardization among programs. There's less face-to-face monitoring, and there have been some concerns expressed about the safety for sicker patients. Now, a frequently studied example for a home-based cardiac rehab is the Heart Manual program from the United Kingdom. Originally described in 1992, this 6-week self-management program includes health education, exercise training, and stress management. With telephone or in-person guidance from a trained facilitator, they find that women and older adults are more likely to enroll in home-based cardiac rehab programs. Another model used in Canada involves 6 months of home-based exercise training with telephone calls from a provider every 2 weeks to monitor progress, to assess adherence, to revise the exercise prescription, and provide support and education. Now, costs of the home-based programs in the United Kingdom and in Canada are largely covered by the national healthcare system in each country. However, such programs are not covered by the Centers for Medicare and Medicaid Services and third-party payers in the United States. One exception is the multi-fit home-based program implemented at Kaiser Permanente, Northern California. This nurse-led case management system starts during hospitalization for an acute MI or revascularization and is followed over the subsequent 6 months by up to 2 nurse-initiated telephone contacts, up to 4 outpatient visits with a nurse case manager, and progress reports based on patient questionnaires. Various hybrid approaches have or are being evaluated. Now, although the core components of center-based cardiac rehab have been well defined, we have adjusted these components in our home-based cardiac rehab scientific statement to include the role of the patient in medical control of lipids, blood pressure, diabetes, and body weight. We believe it's critical for both providers and patients to design home-based cardiac rehab programs to include important and effective risk-modifying health behaviors that patients can directly control: physical activity, healthy eating, medication adherence, and smoking cessation, and stress management. Mobile health technology is a fertile area for innovative models of cardiac rehab delivery. Smartphones provide the opportunity to leverage advances in mobile computing, such as task automation, higher fidelity data regarding patient behaviors and physical activity, and enhanced two-way communication. I'd like to illustrate this with an example. We developed Heartbeat, an application on a smartphone and a smartwatch. Displayed here is the home page for Heartbeat, a behavior change intervention for women with heart disease that my research team, with the support of the University of South Florida, are developing and testing. It offers goal setting, progress reviews, and we have educational videos and a chat function where women can talk to each other, and a health coach monitors these patients from a dashboard. We also have a survey function that I'll explain in a minute. Behavior change interventions must have a solid theoretical foundation, in my view. Scientists in the UK, led by Susan Mickey, have created this behavior change wheel that's helpful in designing just-in-time interventions, and I'll illustrate this. This shows how we use theory to develop our many interventions. Some behavior change techniques are sent automatically on an alarm schedule, say Monday, Wednesday, or Friday at a specific time. And this behavior change technique is from the category social support from the behavior change wheel. And we've personalized all of our illustrations exclusively for women. The goal of just-in-time interventions is to offer the right type of support precisely when a person is in a state of vulnerability, opportunity, and receptivity. So we send a survey to capture their current context. We ask them about a tailoring variable such as their mood to personalize the behavior change technique. And then we implement decision rules. For example, if we don't see any physical activity by 4 p.m. during a day, we can decide which intervention to send and then monitor the follow-up. Heartbeat assesses behavior in their natural setting as they're living their lives. They're called ecological momentary assessments. They're sent 5 random times throughout the day so that we can help personalize their interventions. In this example, we ask patients how many days they reduce their portion sizes. If they reduce their portion sizes 1 to 3 days, we send this intervention 1.6, suggesting a potential relationship between portion sizes and weight. If they report more than 3 days a week, we send a supportive reinforcing message. And so this is just a high-level representation of how the data moves from the smartwatch through Bluetooth to the smartphone. The patient interacts with it, data is sent to the server. It's then moved to the dashboard where the health coach can examine the data and send a reply back to the patient. And so this is just a really brief overview of the dashboard where we monitor their activities, the intervention screens they've acknowledged, the questionnaires they've responded to, the videos they've watched, and what goals they've set. For example, this is the goal a patient has set 41 goals for eating behaviors, 5 of which are for eating vegetables. So we know what's important to this patient. And all of their behaviors are interconnected. So we're using artificial intelligence to try and predict and more precisely personalize our interventions based on patients' behavior. And this is just a view from the smartphone. And we have conducted a feasibility test with women. This was designed with women They were extremely helpful. We did this before we continued development. Now we're conducting a randomized trial to compare the mobile health intervention to a group that receives an American Heart Association cardiac rehab workbook and DVD. And so finally, we believe that technology-enhanced, behavior theory-based cardiovascular interventions holds promise for expanding the reach to women without access to center-based cardiac rehab services, offering just-in-time assistance with behavior change that is personalized to their circumstances and integrated seamlessly into their lives. And I want to thank my team who have been invaluable. And this is the University of South Florida, should we ever be able to return. And I thank you for the privilege of your time.
Thank you, Dr. Becky and Haley, for your presentations. We're going to check to see if we have any questions for you today. One of the questions was, and I'll send this over to you, Haley, or Dr. Becky, either of you can answer. An anonymous attendee says, I had a heart attack at 61, non-STEMI, and 1 stent placed. Metabolic syndrome. Why was I not referred to rehab? I was willing to go and my insurance would cover it.
Good question. Why were you not referred? You should have been.
Definitely qualified, yes. And actually, there are some tools in the change package for a self-referral. It's a new approach. It's from the university, the hospital in Massachusetts, General Hospital, Massachusetts, for self-referral. So if you do find you're eligible, and I would encourage you to reach out to your physician, it may not be too late, and ask if you can do cardiac rehab. The benefits are tremendous, and yeah, check it out.
So the next question is, why are women less likely to take advantage of cardiac rehab? Is it on the physicians because they haven't recommended it?
So a number of different ideas and suggestions. There was a study done with women at the University in Baltimore, and they found that women were not informed about it. So it might have been in the discharge papers, but they were never told that eye-to-eye conversation that cardiac rehab is being recommended for them. There's also evidence to suggest if your family's in the room and they hear it, especially your kids, kids telling their mother, Mom, this is something you need to do, is more of a motivator for some women. And specifically for African-American women, there's a tendency to be a superwoman, and I can do this on my own. A lot of going on, and just so many other responsibilities that this is just put in the past. It's not a priority for some women. So a lot of different ways for women to really take on their health and take control. And yeah, physicians have big time role. So making sure that referral happens. And again, the care coordination, making sure that conversation is happening, having the phone number, having your first appointment before discharge is another key element. Dr. Becky might have more insights.
No, those are most of the system barriers. In addition to that, as I mentioned, women work. They take care of everyone else but themselves. So they tend to not enroll if they think it might inconvenience someone else.
And last question, Dr. Becky, I think this is specifically for you. How does your program incorporate group support for patients receiving home-based cardiac rehab?
That's a great question. I just briefly mentioned the chat function. We have a chat function where they can talk to each other. And now I do monitor it because we don't want misinformation being transmitted in the group. The one thing we're trying to do that we haven't done yet is to have patients meet before they start the home-based program, but that kind of defeats the purpose of it being home-based. That's the only thing, is that sometimes women wish they could meet each other before they start the chat function, but we're trying to protect their privacy. So they are, if they're willing to give their information, they can meet, but otherwise we want to protect any privacy concerns.
Thank you all so much. I'm going to turn it over to Selena, who will close us out for day one.
Thank you so much, Kalandra, and to all of our speakers today. My goodness, I have learned so much, and not just from the speakers that we had, but from your questions as well. So thanks again for that, and we look forward to more interaction tomorrow. I wanted to just remind all of you that we can continue this very lively conversation by having you continue to send us your questions and comments, as well as providing feedback through the evaluation forum. So just to summarize our afternoon together, I've got so many notes, so I'm not going to go through each and every one, but I just want to highlight the things that really stood out to me. From our first session, we heard, of course, and I think this has been a resounding experience across the entire healthcare system, that there's just been this dramatic decrease in visits to the ER and to the hospital in general, and all of that resulting in worse outcomes. And so it just is a reminder to Women Heart that we need to continue to remind our community to make sure to go to the ER. And I know that many of you have repeated that notion, that if they're experiencing symptoms, to not ignore them and to seek care. We also heard about I think not just the growth of telemedicine, but the notion that this is a trend that is here to stay, and that will really change the way healthcare is financed in this country, in terms of reimbursements, but also how care is delivered, not just medical care, but support services. I mean, it's really affirming to Women Heart that our change in tack to move our activities to the online platforms early on was the right move, and very much aligned with the thinking across the entire healthcare system. And we're going to continue that as we go forward here. Of course, we know and understand deeply the devastation of racial disparities that existed long before the COVID pandemic. And we are reminded by Dr. Jean and Dr. Crabb that these are inextricably linked to social determinants, which further underpins Women Heart's renewed commitment to addressing these disparities and their causal social determinants of health. And I want to also give a mention to Ryan's point around working in coalition during these unprecedented times. I certainly have benefited greatly from listening to my peers and other organizations around the country in terms of how they're dealing with questions and trade-offs and decisions that they've never had to face before. I mean, it's really informed the way Women Heart has dealt with this moment of collective national crisis. I mean, the second half of the day, we heard from some of our speakers about the very real challenges that women face before, during, and after diagnosis. And in particular, Kelly and Dr. Bates spoke about the interplay between heart disease and mental health, and making sure that mental health is part and parcel of caring for the entire patient. And the importance of making sure that there is voice and choice in their care, which I think is really fascinating and really vital to better outcomes. And of course, I think we all really glommed on to PTG that Dr. Bates mentioned, the post-traumatic growth, which I certainly have taken note and taken heart of during this talk. And then lastly, we wrapped up with Haley and Dr. Becky talking about the importance of cardiac rehab and some really good signs for hope in terms of where we're headed with great new models of virtual innovation in cardiac rehab. And that, again, this feels like it's not only is it starting, and not only are these kind of pilot projects, but they are really going to be here to stay as a permanent feature of the healthcare landscape. So like I said, I've learned so much and I have so much more here, but I want to thank all of you and thank our speakers in particular for their dedication and commitment and passion that came out so clearly during their talks. And we look forward to hearing from our next set of speakers tomorrow, where we're going to focus a little bit more on the policy front looking at the lifespan, and then how organizations like Women Heart can further provide support for women with heart disease. Thank you very much, everyone. Again, some reminders here that this is a recorded conference, and we will provide the information and presentations after. You can opt to attend some or all of it, and I will say that the majority of you stayed on for all of it, so we're very pleased about that. And when you do sign on tomorrow, you will use the same link that you used to sign on today. Please, please, please fill out the evaluation form and make sure to find us on all of these social media platforms and engage with us. And we look forward to seeing you all tomorrow. Thank you very much.